The Royal Commission is now in session.
Good morning, everybody, and welcome to this hearing in Homebush, and also welcome to those who are following the proceedings remotely. I'm sorry for the delay in starting. That sometimes happens with hearings. There are matters that need to be attended to. Before asking Ms Eastman what will happen, I shall wish on behalf of the Commission to acknowledge and pay our respects to the traditional custodians of the land on which we're meeting today, the Wongal people, and we also pay our respects to First Nations elders past, present and emerging, as well as to all First Nations people who are present today or who are following the proceedings. Yes, Ms Eastman.
Commissioners, you asked me yesterday what was going to happen today, and I said I'd tell you in the morning. We have a very busy day, and it's likely that the hearings will go beyond 4:30 today, but what we'll seek to do is to structure the day so that there's breaks between the witnesses. We have 7 witnesses in total giving evidence today, and the order of those witnesses may be subject to a range of issues that arise during the course of the day in terms of timing and the like. So we're going to start this morning with Catherine McKenzie and Lynn Porter, who will give evidence in relation to the Community Visitors Scheme. And Ms Wright will be taking that part of the evidence. And Commissioners, if you can excuse me for the next hour or so, what we hope is that this evidence will take about an hour, and then there'll be a break for the morning tea adjournment, which should be close to or shortly after 11. So if the Commissioners can excuse me, thank you.
And thank you for that. And yes, of course, we do excuse you. Are there any further appearances to be taken for today?
Good morning, Commissioners. My name's McMillan, initials KA.
Would you mind speaking into that microphone?
Good morning. My name's McMillan, initials KA, Queen's Counsel. I appear on behalf of the State of Queensland for the in relation to the 2 witnesses, Ms Barnett and Ms Nash.
Thank you very much. Yes. Sorry, is there something else?
Yes, Commissioner, I appear...
Someone's leaping up, yes.
Hunter, I appear for Karen Barnett.
Thank you, Ms Hunter.
Mackenzie, Commissioner, I appear for Tracy Nash.
Thank you.
May it please the Commission, Healy, I appear for AAJ witness.
Yes, thank you very much. Do we have enough room at the, what is a note?
Arrangements have been made, thank you, Commissioner.
Otherwise you can kneel or something and we'll fit you in. All right. Yeah, Ms Wright, yes.
Yes, Commissioners, I call Catherine McKenzie and Lynn Porter.
Please do sit down, and each of you may take the oath or affirmation as you wish. Thank you.
Do you both take the affirmation?
Yes.
Do you solemnly and sincerely declare and affirm that the evidence which you shall give shall be the truth, the whole truth, and nothing but the truth?
I do.
I do.
Thank you very much. Ms Wright will now ask you some questions.
Ms McKenzie, I'll start with you. Could you state your full name, please, to the Commission?
Catherine McKenzie.
Are you the Director Disability at the Office of the Ageing and Disability Commissioner?
I am the Director of Operations at the ADC.
I see, thanks. And you've been in that role since the creation of that office in about August of last year, is that right?
Yes, I transferred in July last year from the Ombudsman's Office to the ADC.
And what was your role at the Ombudsman's Office?
As Director of Disability.
You've prepared 2 documents for the Royal Commission. One is a short summary summarising the New South Wales Official Community Visitors Scheme. And did you also prepare a submission in response to the Royal Commission's issues paper in relation to health issues affecting persons with intellectual disability?
Yes, that's right, which drew heavily on the work of official community visitors, including Lynn.
And those documents, Commissioners, are behind tabs 1 and 1A of Tender Bundle C. Now, Ms Porter, could you state your full name for the record, please?
Lynn Marie Porter.
Are you an official community visitor in New South Wales?
I am.
Do you hold your appointment under some New South Wales legislation?
Yes, I do.
And do you work in a paid capacity?
I do.
All community visitors in New South Wales are paid as opposed to volunteers?
That's correct.
And that's a difference with the Victorian scheme, is that right?
That's right.
You were first appointed as a community visitor in 2001, is that right?
Yes,
Under the legislation, your appointments can't exceed 6 years in consecutive appointments, is that right?
that's right.
And so you've had a number of breaks between 6-year consecutive appointments, is that right?
That's right.
So you've held appointments between 2001 and 2007, and then between 2011 and 2017. Is that
Yes.
the case?
Yes,
And you were most recently appointed again in 2018.
that's correct.
What areas of New South Wales do you look after?
I visit in the Blue Mountains, Western Sydney, southwest Sydney and the Hawkesbury.
How many visitable services, as they're called under the Act, do you visit?
Currently I've got about 50 homes that I'm responsible for.
And do you visit each location twice a year? Is that how it works?
Yes, that's minimum visits.
Okay. And you haven't prepared a statement for the Royal Commission because you weren't asked to, but is that the position?
That's correct.
Okay. Now, Ms Porter, could you just describe briefly the nature of your role and what your particular responsibilities are?
So official community visitors have the power to enter a visitable service, supported accommodation service, at any reasonable time, and we do that unannounced. And when we enter, we speak to any person there, including staff members and, of course, residents, check any documentation in written form or electronic, and then we do a report, an electronic report to the service, raising issues of concern, and they have a particular time frame for response, and then if there is no adequate response, then we have ongoing dialogue with the service.
Okay.
So the role of a visitor is to try to we're the voice for people in care, and we try to raise issues on their behalf to improve their circumstances.
All right. So your ears and eyes on the ground, so to speak.
Exactly,
And you
yes.
have the right to speak to anyone there, the residents, the staff, to look at records and to enter at any time unannounced.
Yes.
Now, just before I ask you about health-related questions, Ms Mackenzie, you have provided some data in your submission to the Commission. How many official community visitors are there in New South Wales?
There's 32 official community visitors. The scheme can support, budget-wise, can support a maximum of about 40 visitors. We're currently recruiting to fill some of the vacancies, but yeah, about 32 at the moment.
All right. And the information you've provided to the Commission is that there are 2,051 visitable locations in New South Wales falling under the scheme. Is that right?
That's right.
And 86% of those are accommodation services where an adult with disability or older adult resides in full-time care.
That's right. So, yeah, vast majority have intellectual disability.
And so the remainder, the 14%, are out-of-home care residences for children.
That's right, and assisted boarding houses.
Thank you. Now, the data you have provided to the Royal Commission in your 3-page summary is that in the 2018 to 2019 year, community visitors raised a total of 6,125 issues arising out of visits.
That's right.
And 77% of the issues related to disability supported accommodation.
That's
Is
right.
that the case? And then if I switch to your response to the issues, the Royal Commission's issues paper, which is the longer document, you say that healthcare issues accounted for 20% of all issues raised by community visitors in 2018-2019.
In relation to disability supported accommodation services, that's right.
Okay, so that was about 950 issues about healthcare.
That's right.
Now, that covered a range of issues. Is that the case, including access to timely and appropriate health services, and the adequacy of support provided by health staff.
Yeah, that's right. So it covers within the scope of issues relating to healthcare. It's quite a broad scope. It includes where the visitor identifies concerns about the extent to which a resident's needs, health and related needs, have been identified, and the extent to which their action has been taken to address those needs.
And one of the first issues you raised in your submission is about access, and you refer on page 3 to disability support staff being the gatekeepers for residents' access to GP and health services.
That's right. And I think, part of the point that we were making there as well, OCVs certainly see that disability support staff, in relation to some of the issues that I know have already been canvassed in the hearings relating to diagnostic overshadowing, it definitely happens in health services, but what OCVs see is that it also happens within disability accommodation environments, and very much people with disability in residential care are, for the most part, heavily reliant on disability support staff to be able to identify where there's a need for them to access or gain health support. And in a range of matters, OCVs have identified that some health issues weren't sufficiently or weren't identified in a timely way because the issues were seen as being part of the behaviour of the individual or part of their disability, rather than recognising that there was a health concern that needed to be, that they required some health support.
Mm-hmm. So it's not only health services who are or who engage in diagnostic overshadowing, it's the disability support staff. And that's something that community visitors have reported.
That's right. And overall, OCVs, and Lynn will obviously be able to talk to this in some detail, but OCVs, most of their contact is with, other than the residents, and that's a heavy focus for them. Other than that, most of their contact is with the support staff. Mm-hmm. They are able to see really clearly the critical role that support staff play and in enabling access to necessary health supports, but also the critical role they play in providing support to individuals to help them to better access health services, to overcome some of their resistance to treatment or to assessment, to facilitate their access, but to provide appropriate support in accessing those services. OCVs are in a really valuable position of being able to see. They're not visiting health services, but they're able to very clearly see the impact on individuals of their limited access to health services. Where there are issues in the support that they receive with health services, they can see very clearly the impact on those individuals. And what they also see and report on really regularly is they're in a really useful position of being able to see how important that coordination is between health services and disability providers.
And just to give an example, you've provided some examples of that sort of problem which has been raised by community visitors. You've said, for example, there was a case involving recurrent urinary tract infections, and the person's confusion was put down to their disability rather than a treatable cause, and there was delayed treatment in that case.
That's right.
And you also gave an example of recurrent falls being attributed to progression of ageing and disability rather than something that required a health service. Yeah. Do you see that, Ms Porter, in your visits, that kind of issue?
Yes, I do, in particularly around behaviour that sometimes in services where the person's primary diagnosis, if it's a mental health diagnosis, and the staff generally are very clued into a person's mental health needs, but there may be some emerging physical health concerns that are completely missed because staff are so focused on on the mental health, and that's where their training is. Equally, in the group home model with the disability support workers, their role is absolutely critical in relation to a person's health, and actually recording and ensuring that the relevant documentation and appointments are completed for a person. Time and time again I see out-of-date plans, out-of-date assessments, recommendations not being implemented. So people are falling between the cracks because nobody's connecting the dots. There's no, at the group home setting, all staff are assuming that somebody else has done it. Nobody's actually checking the documentation, and that is critical to ensure a person's health needs are being addressed, that the recommendations that come out of any appointment with a GP initially are followed up.
What have your observations been about how well staff identify or recognise health issues? What sort of systems are there in group homes for monitoring health issues when you say things are missed and fall behind and are out of date?
Yeah, I think in particular with people with autism who have, tend to have a very high pain threshold, or if a person's non-verbal and has some behaviours of concern, that could particularly be in relation to pain. It could be pain related, quite often, with dental pain, and it's put down to pain, it's put down to behaviour, and they're given PRN for their behaviour, to manage the behaviour. So they're not looking at the person, and they're just saying that it's that's just their behaviour, and they're not looking further, and they're not making records, and they're not taking a person to a GP, which is what any of us would do reasonably if a family member had pain or appeared to have pain or was unwell. You would do something, but it's just or relevant handovers. Staff aren't saying to the staff coming on, "Oh, look, just watch Johnny because he's had a bit of a temperature or whatever." It's not. The concern on the ground isn't there. Sometimes disability support workers are just not supporting a person and their health needs the way that they should.
Or even recognising that something is a health issue. How do residents access general practitioner support or other medical help? Is it through home visits, or are they required to be taken to a GP? How does that work?
Well, I would expect if a person's living in the community and they're integrated into their community, that they would be first there would be choice around the GP that they would access, and that would be around a whole range of things. And what I generally see is a GP selected for convenience, and that's staff convenience. So it may be that when you go into a group home, it's very common to see all residents in that home seeing the same GP. And that is because that GP is local and will come into the home to do home visits. And so sometimes there's just not choice. Families aren't even consulted. It's a phone call to say, well, we're seeing this doctor, and I see it consistently, and I see it concerningly in relation to women who have a complex trauma past and are living in an all-female group home, and that group home is staffed by all females because of that complex trauma of sexual abuse, and yet the staff have elected for those women to see a male GP because the GP's across the road from the group home.
I see, and the GP either comes to the home or they're taken, and the choice of GPs made by the staff, and you're saying that's a matter of staff convenience. And is that an issue that you've raised?
I have.
That particular home?
Yes, I have many times. I've raised the issue with the service to ask what choice did the person have in relation to that doctor being chosen. I can give an example, if you like, a very recent one.
Yes.
From last night when I did a visit. A resident had been moved from a supported accommodation home into a complex health home because the health needs had increased so much. And part of the recommendation and then the transition plan was that that resident needed to continue to see the GP of 10 years or 15 years because of the person's complex health needs. So then I turned the next page to see that the GP that visits the house is now that person's GP.
And that's a different GP.
Yes, yes.
Yeah.
So obviously I've raised that, and similarly that person needed to see particular specialists and a dentist, a specialist dentist. All of that has been disregarded because there's been an action by the staff to choose the GP that goes to the home, the dentist that all the residents go to, the neurologist. So it's...
Yes. So you've raised that with the staff at the home, and
Yes.
how are you able to escalate that?
So in my report, I do a report to the service, and that's an electronic report, and that goes to generally the manager of the service and sometimes the CEO, and I raise that in relation to that resident to say how was that choice made and why, and what involvement did they have and what involvement did family have.
Would you expect to receive a response from management?
Yes.
And if the response is not satisfactory, what mechanisms are there for you then to escalate?
So I communicate and I have dialogue with the service. It might be over the telephone, I might meet with the management, I might do a follow-up visit and ask that the manager come to the house and meet me so we can have a discussion there. The idea and the whole philosophy of Community Visitor is to try and raise issues at that grassroots level, but you also want to make sure that the person's rights are being respected and that they're having choice. That I could have, you could have, the person with a disability should have that as much choice as possible.
Right. Now, to what extent are annual health assessments...
Excuse me, just before you go on, so what's the next step if they absolutely refuse to do anything about it?
As a visitor, I'm a bit hamstrung in how I can pursue that issue. So what I would do is talk to the community visitor team and ask for some guidance, suggestions as to how to progress the issue, and that's really as much as I can do as a visitor. And it's very frustrating because you do see time and time again where people aren't having choice around the health practitioners that they access.
So there's a number of mechanisms, I suppose, that visitors can pursue. As Lynn said, it is designed to be that mechanism to try to achieve local resolution, but where the visitor feels that they've gone as far as they can, the response is still inadequate or is missing the point, or the service just isn't taking action, as Lynn mentioned, should raise that with the Ageing Disability Commission, the community visitor team, in a number of matters, and depending on the nature of the issue that's being raised, we facilitate the referral of those issues across. In the legislation, it refers to visitors being able to refer matters of concern to other appropriate bodies. So the NDIS Commission, in relation to some of the NDIS providers, which are the services that the visitors are going to, there's the ability to refer matters of concern across to them, or indeed for the visitor to be the complainant, to make a complaint to the Commission.
And I have done that in relation to other matters, generally around violence and abuse.
The Ageing and Disability Commissioner has certain powers under the Act, does he not?
Yeah, we do. The Commissioner does, but primary jurisdiction over NDIS providers sits with the NDIS Commission. And in fact, our legislation requires us, where we receive a report that could be the subject of a complaint to the NDIS Commission, we must refer it across to them. So the role that we play is essentially facilitating the referral of that information across to the NDIS Commission, and where there are issues in the response that visitors receive, we seek to escalate that.
What proportion of your visitable services involve people who are on the NDIS?
So of the 2,051 visitable services, 86% are disability supported accommodation settings. So the vast majority of the visitable services that OCVs are going into are disability supported accommodation settings involving adults with disability.
But would they all be on the NDIS?
Yeah, all of those services are NDIS registered providers, yes.
And the boarding houses?
And separately, so there's a small number, there's 17 assisted boarding houses with a mix of adults with disability and adults with other additional needs relating to age, frailty, mental health or other kind of additional needs. Some of whom, some of the residents are NDIS participants, but not all. Some are over 65 and ineligible for the NDIS. Yeah.
What is your experience with complaints made to the appropriate body within the NDIS?
We're having some issues at the moment in relation...
Tell us about the issues.
Yeah. So there's a number of matters that we've facilitated, either complaints to be made by the visitor to the NDIS Commission, or indeed the referral of information across to the Commission. In relation, and we do have some agreed arrangements in place between the Community Visitor Scheme and the NDIS Commission for the provision of that information, requests for further information from the visitors, and the interaction between OCVs and the Commission. We're having some issues at the moment, and Lynn, is one of the visitors who has made a complaint to the Commission, raising concerns about circumstances for individuals, but also raising concerns more broadly about particular providers. And in a number of those cases, the advice back to the visitor, well, one, the visitor didn't receive information back from the Commission. It was only when they followed up. But two, received advice back that they couldn't provide information about what action had been taken or the outcome due to privacy concerns. From experience in handling complaints at the Ombudsman's Office, including complaints by OCVs, there is information that can be provided that doesn't breach any privacy issues or barriers on disclosure of information by the Commission. So at the moment, we're seeking a meeting with the Commission to seek to resolve these issues so that the complaints that are made by OCVs, they get a timely response, but also they get information back about what action has been taken on those matters. Importantly, the matters that OCVs are raising, and certainly those that they're seeking to escalate to a complaint, are only after either they're really significant issues that the visitor always provides an opportunity for the service to respond first, but they're either really significant issues that they want to get before the Commission or the other kind of complaint or oversight bodies, or they're matters that the OCV is sufficiently concerned about and they've gone as far as they possibly can within the scope of their role. So the point at which we're making a complaint, they're not... by no means, they're not trivial matters, and they're not matters that, in the main, OCVs are just referring across for information. They're generally matters that they're seeking some action on, or consideration, at least by the Commission, to take action on.
And what's the procedure? Is the OCV contacted by the Commission in order to understand more about the complaint, or is it just a matter of filing a written complaint and then it's up to the Commission?
So the process is that the OCV in the first instance comes to the OCV team. We do kind of an initial conversation, screening really of those matters, primarily to make sure that the visitor has raised it with the service first and provided an opportunity for them to respond. And then we facilitate, so we'll pull that information together on behalf of the OCV and send that information in written form across to the Commission, so it's clear what the key issues are, and also indicates, provides the contact details for the specific OCV, indicates whether they hold other relevant information that could be of use to the Commission in relation to those matters. But also the process then, once that's received, is the Commission is to contact the OCV directly to discuss that matter and how they wish to proceed. So whether the OCV wishes to be the complainant in that matter, whether they wish to be identified as the complainant, or whether they just wish to provide information for the Commission to be able to take whatever action it sees appropriate.
Are there circumstances in which the person with the disability himself or herself is the complainant?
There's not generally via the ones that OCVs make. There have been, actually, sorry, there have been some where the adult with disability has raised the issue, particularly with the visitor. The visitor has raised it with the service on their behalf, still hasn't had any traction on that issue, so has raised it and it's gone as a complaint to the Commission. So it's by the visitor on behalf of the resident. Yep, certainly.
Thank you.
You mentioned access to GPs and some issues around that. I just want to ask you both about the CHAP tool, the Comprehensive Health Assessment Program tool, and the Commission heard some evidence yesterday from Dr. Lennox, who designed it. Do you see evidence, perhaps starting with you, Ms. Porter, of it being effectively used or used at all? Disability supported accommodation?
I see examples of it being effectively used, and I see staff very proactive, and I see instances where that CHAP tool has become a tick box exercise, and when you actually go through the booklet, you see that time and time again it says persons refused, not applicable, particularly in relation to women's health.
When you say persons refused, that the resident has declined to accept
to be examined,
treatment, and it's noted in the CHAP tool.
Yes, but there's no follow-up, so it's recorded that hasn't been addressed. So the person's refused, or they've said that that's not applicable, but there's no follow-up. So it becomes, instead of it becoming a living document and a document that is enduring and people are looking at that and making sure that any recommendations or any outcomes are addressed, it's just filed. And some group homes I go into, they're out of date. They're 2 years out of date.
Yes.
Plans are out of date. It's not unusual to see health records that are out of date and nobody at that grassroots level in the group home taking responsibility for driving that through to the point where you and I would address our health concerns. They're not being addressed.
I think in some instances too, what OCVs particularly have raised concerns about also are for example, women's health screening as part of is a key part of the CHAP tool, relevant obviously for women. But often, what visitors will raise is that, as Lynn is saying, it either will have NA on it, or there'll just be a big line through it, despite it being a woman with disability, but a woman who should be having the same health screening as any other woman in the community.
And so that is an issue raised more broadly by community visitors about the use of the CHAP tool in particular, or you're talking more broadly about barriers to, or the lack of support given to residents to access?
Yeah, I mean, some of the issues, I think, with the completion of the CHAP tool by the GP rather than by the service provider are just recognising the need for example, women with disability to have access to the same screening and assessments. I think there's a number of kind of factors that play into that, including, as Lynn was mentioning, where they record that the person refused to have it. I think there are a range of people with disability, including those in residential care, who don't like being touched, who don't like having assessments, who don't like being in contact with people they're not familiar with or in settings they're not familiar with. The concern, though, that's been raised is, and particularly by OCVs, as well as I know through the Ombudsman's death review reports, is that it's really difficult for OCVs to see that any work has been done with the person with disability to help them to be able to address those issues of resisting access or resisting treatment or resisting necessary health assessments.
And that would include exploring alternative options.
Exactly.
For example, I think one of you has given an example of a resident refusing mammograms, for example, and that there may be alternatives such as ultrasounds that should be explored, but you don't see evidence of of that kind of thinking.
It's not. So those kind of, I suppose, reasonable adjustments. So what other options are available for the person to still enable them to access necessary health assessments and treatment? I think, where that becomes, it's an issue in terms of accessing the health screening and the services that they need to treat the health concerns, that identify and treat the health concerns that they have. But it particularly becomes an issue at the other end, where treatment limitation decisions are being made based on a perception that the person will object to having that treatment. So individuals who have been diagnosed with cancer, who anyone else in the community would have the option of, or where it was appropriate, would have the option of treatment, chemotherapy or other treatment. There'll be information recorded to indicate that it wouldn't be appropriate for the person because they wouldn't be able to stand, either wouldn't be able to sit still, or they wouldn't be able to, they would be too distressed by the treatment. And I think they're not without validity. Some people would be distressed by that, and some people would find it difficult to remain seated, and I think particularly what OCVs see, and particularly ones like Lynn who have visited over a long period of time, is that no work, in most cases, no work has actually been done with those individuals to give them the best chance of being able to access and receive that treatment. So their resistance to medical treatment, the way that's responded to is the prescription of an anti-anxiety medication to have immediately before having a blood test or similar treatment. But it won't, that kind of resistance to medical treatment won't form part of a behaviour support plan. So there's no, the opportunity to actually work with the individual to assist them to minimise their resistance to treatment, to make it easier for them to receive the treatment that they need, is effectively lost.
And Ms Porter, what sort of adjustments or actions, in your experience, could be taken to assist those persons to access medical treatment?
I think a participant in the NDIS has support coordination, and I know that those dollars are limited, but if there could be some additional funding for support coordination, specifically to look at a person's health needs and to ensure that these things are taking place. As far as support workers being engaged at that level and supporting a person to go through a particular, for an appointment or through a procedure, there's tools and resources out there. They're there for staff to access. But when I ask that question, the staff they stare at me blankly because they're not aware that these tools and resources are there. CID have tools, and that's the frustration, is that the staff could have access and could have better support to support the person. And I don't see that. And I see no planning in relation to a person having to have a medical appointment. It's made 2 and 3 months ahead, mostly. If you're seeing a specialist or a dentist, it's much longer. And there's no care or concern around the staffing and the rostering. So sometimes it might be a casual staff member that turns up, or agency staff member, to take a person to a medical appointment that's highly anxious. And of course they don't go. And of course the appointment's lost and there needs to be a follow-up appointment. That is so fundamental to supporting a person. When the appointment is, but somebody at that level, at that group home level, needs to be oversighting that and making sure that the person is prepared to the best of their ability to undergo that appointment, to go to that appointment, to understand it, social stories. And I see good evidence, don't get me wrong, I see good evidence of support workers doing a lot of good work with people and supporting them. But equally, I see really poor evidence of support workers not supporting a person, and they have to go through that all again, and meanwhile the person's health needs are just not being addressed.
You mentioned social...
Can I just come in here?
Yes.
Where you see good practice compared with not such good practice, do you see that relating to the supervision and the management and the lines of you know, the lines within the group home?
I do.
Yeah.
I do. And it's not necessarily that you need even a team leader or a manager on site. You need somebody that's oversighting correctly and supporting their staff to make sure that these things are done, and accessing social stories. I see a service that do this really well, and they don't actually have a team leader on site, but the team leader's very mobile and is available to the staff. They access the tools, they get the right staff member that knows that person well, and they take them to the appointment. They change the rosters. They do all of that pre-work to make sure that the appointment is a success.
And the others? They're not...
Just no, there seems to be, it's just chaotic sometimes in group homes. You go in and it's, there's an appointment in the diary, but no one's turned the page to see that appointment, and no one's done any preparation around that. It's just a surprise. So whoever is coming on shift, and then they take that person from the home, put them in a van and drive them to a hospital or to a doctor's surgery, with no preparation. And you see it time and time again. They say, oh, well, we just have to transport them. Well, actually, no, you don't. You're a support worker, and it goes beyond that. So I think in some services, it's working fantastic. And, you know, the line managers are across it, and the staff, they know the expectation. The service are very clear about what the expectation is. So and it's not fair and it's not equitable that people, your health outcomes are dependent upon the attitude or the quality of the support workers, and it's enormously frustrating. And because I do see good evidence of it, and it should be across the board, and it's not.
You mentioned that you saw a particular service where this is done well.
Yes.
Could you tell us which one that is?
Afford.
Thank you.
And you mentioned...
Who are the service providers in general? I don't mean to identify people. What can you give us an indication of whether they're typically running a number of homes, group homes? Are they individual service providers? I'd like to get a sense of who you're dealing with.
Yeah, so most of the providers operate, so it's quite rare to see a provider only with a very small number. There are some that only have a few houses, but yeah, it's a mix of providers of really long-standing and that are really huge service providers that go across multiple states and territories, to others that are just within New South Wales but equally have existed for a long period of time. There's also some providers that have come into the market only since the NDIS started, and some of them, I know OCVs, including Lynn, have had a range of concerns about that they haven't, their understanding about actually what needs to be done to meet the needs of individuals, what kind of compliance with practice standards looks like, just isn't at the same level as the other providers, and presents a risk to some of the residents that they're seeing.
I think on that, some of the new providers that have popped up with the NDIS, they're very small, and they've required only a third-party verification to launch into service provision, and that is very problematic because their policies and procedures are quite inadequate. The staff, I have one service where the staff are, they're not even support workers. They come from the community. They're very, very, very good hearts, but they have no understanding of people with disability and their needs. So they just can't even meet that fundamental, that very low-level bar. So there's some emerging service providers that have come into the market with NDIS, but mostly the services that I visit, they're long-term providers, and they're very big. And it's good as a visitor. If I visit a service and I visit 5 or 6 of their houses and I've got breadth within that service, I can see the quality or not. Is it a systemic issue across the service, or is it particularly in one home? When you've only got one service, it's difficult to obviously make that call, but it's variable and it shouldn't be, and that's the frustration that I see in that, I'll be in the same suburb and I can go to 3 homes and I can see such variable service provision, and in relation to health I can see, the same. It's some services do particularly, they may just do complex health, some services do complex behaviour, you get some services that think they can do it all, and sometimes not very well. If they've got, if you see a health model predominantly trying to take on a person that's got behaviours of concern, it's problematic because the compatibility of the people living together is just not good.
I mean, what visitors have also, which picks up some of Lynn's points, some of what they've pointed to is, where you've got a provider that has a really good culture and a good, and from leadership down, really puts an emphasis on health needs and identifying the needs of individuals, and good, as Lynn was mentioning earlier, good monitoring system for how they stay on top of some of those issues to make sure the person's needs are being met. You see better practice on a range of fronts, including, in some of the matters I know that Lynn has raised previously and other OCVs, where there are particular providers who have put in place local arrangements with their local hospital, so have put in place arrangements for, when one of their residents is admitted to hospital, the process that will be followed, arrangements around discharge planning and the communication between the service provider and hospital staff. There's requirements at the moment in health policy that they set up local arrangements with disability providers, but that as a rule doesn't happen. There's very few of those that are currently in place. The ones that have kind of been put in place have really been led by some of those more proactive disability providers who have taken the leadership and ownership to reach out to particular hospitals to say, this is the client group that we have, or the people that we support, and to seek to put in place some of those local arrangements.
Mm. And I think, can I just say, in relation to involving the person with the disability, so many times you see that they've had a communication assessment, that tool is there, and that's for everyone that interacts with that person to utilise. And generally you'll see it in the filing cabinet, or it's not the fact that the dollars have been spent to do a communication assessment to enable that person to have a voice and to communicate, and then to see it not being utilised. Even that, for, when a person goes to hospital, if you see a really good hospital plan, it's got all of that information. It's got how do we communicate with the person, what works, what doesn't. It's there, and it's just, even for the ambulance officers, if you see a good hospital plan, it sets out what the diagnoses are for that person, medications, how to communicate with them. It's got the critical information just in a few pages, and then the staff, good staff will support that person completely. But you hear of cases where a person is simply put in an ambulance with a staff member they don't know and taken to a hospital they've never been to.
Well, we had a hearing about group homes in Melbourne, and one of the matters that came out of that was the question of choice. People with intellectual disability or other disabilities having a choice as to what group home they went to. Now, what you're telling us is there's a few things you need to know in order to make an informed choice about where you live. So how does a person find out the things that you've been referring to?
I think that's a really good question. I mean, ultimately, I know the NDIS Commission obviously is doing audits and doing checks of the providers. I suppose there's a question about the extent to which key information, like we've been talking, that actually makes a difference to people's lives, things around not just, I suppose, culture and how the service operates. But I know one of the things that Lynn and other OCVs have really highlighted is you'll find a range of providers that have excellent policies in place and really good guidance for staff, but OCVs repeatedly see that's not implemented. So you can have fantastic policies, but actually not that kind of follow through on the ground. And I think some of that information, how do you make that information available to people with disability and their family to be able to, as you say, to make an informed decision about services that they would choose to use.
So what's your suggestion?
I think part of it relates to the extent to which those audits pick up qualitative information, not just, I know in the past quality checks have been primarily about whether key policies are in place, which doesn't provide the full story. So I think ensuring that the views of residents, existing people with disability are heard as part of that quality assurance process. But I think it's also about looking at, what information can actually be made public. I don't know what currently is made public by the NDIS Commission or what that focus is, but certainly I think some of that more qualitative information that actually gives a fair and accurate reflection about what's happening in that house and how that service operates is the valued information.
I think we should probably give this right an opportunity to ask a question.
That's quite all right, Your Honour. You've both raised a lot of points. Just picking up on something that Ms. Porter you mentioned. You said in some group homes, some of the staff aren't even disability support workers. Is there no, and perhaps it's not a question you can answer, but to your knowledge, is there any mandatory minimum requirement for training or qualifications for a person who's a disability accommodation support worker?
It's dependent on the service. I mean, routinely staff had to have a disability certificate 4 in disability or a Cert 3 and working towards a Cert 4. But what I have seen in the, particularly in one new service, or two new services, the staff did not have any qualifications. One had an aged care nursing AIN certificate, and the other staff did not. So my question to the service was, well, what is the minimum qualification and what are you doing around that? Because, and even ongoing training for staff is very deficient.
And you referred to complex health models in some group homes. Does that mean group homes where there is a registered nurse or enrolled nurse on staff?
Yeah,
Is that essentially what that means?
Yeah, so the complex health is the high medical needs, and they're staffed by a registered nurse and 2 AINs generally in the group home. I have services that have gone from, they were a complex health model and with funding were not able to sustain that model, so they went to a DSW model. And that model operates with a mobile clinical nurse consultant that might go across 5 of their houses. So daily there is a nurse just oversighting if there are any concerns, any medical concerns. And there's also complex behaviour models as well. And they, a lot of the staff that staff those homes have a background in mental health nursing.
So it should just we certainly wouldn't be saying that group homes need to be staffed by nurses. It's about having access to that kind of more specialist support when that's needed. I think that part of the critical thing that visitors across the board have commented on a range of these issues have existed well before the NDIS, but one of the issues certainly since the NDIS that visitors have noted is reduced access to training for staff, that they just don't see evidence of team meetings, they don't see evidence of kind of regular access to training by staff that it's more kind of online modules that staff access, but it's not a regular feature of what staff can access.
Is that a consequence of the changed funding model post-NDIS? Is that the issue?
Yeah, I think it's pre-NDIS, obviously services, the same services were funded by block funding, so generally had a bit more leeway with the funding to be able to allocate some of that to staff training and to be able to take people offline and backfill those roles to enable them to have training. Certainly the feedback from visitors and from the providers is that that doesn't exist. Well, certainly the model is individualised funding, and that there isn't that scope to be able to provide the same access to training, whether that's accurate or not, but certainly that's the feedback from providers to visitors.
Yeah.
You both also touched on the question of hospital admissions and also discharge and transfer of care back to the group home. Ms Mackenzie, at page 7 of your submission, you say that a strong theme raised by community visitors concerns the importance of good working relationships between health services and disability accommodation services. So I just want to explore that with you about hospital admissions and then discharge home.
Yeah.
What problems, if you could provide the Commissioners with an overview, do community visitors report associated with hospitalisation of residents of disability group?
Yeah, so there's a range of issues. One, majority of hospitalisations are unplanned admissions. They're in response to critical health issues that have emerged. So the ability to do some of that pre-planning generally isn't there. But what is really critically important is that at the time that the person is admitted to hospital or presents to hospital, that they're, as Lynn has flagged, that they're supported by disability staff that know the person, that are able to provide, quality information across to the health staff, to hospital staff, that they have access to a hospital support plan or similar that provides a really simple, easy to read, brief information about the critical information that hospital staff need to know to meet the person's support needs.
Just sorry to interrupt you there, but who's responsible for preparing a hospital support plan?
So many disability providers have done that work, whether it's called a hospital support plan or there's also a program that the Ageing, Disability and Home Care, the department rolled out some years ago that still exists to some extent, called Hospital to Home, I think it's called. Sorry, I've forgotten the name of it off the top of my head. But is a package of information that the provider has ready to go when the person is admitted to hospital that they can hand over. There's a number of hospital health policies that already exist that kind of point to the importance of that communication between the disability service staff and hospital staff at that point of admission.
And you're referring to New South Wales Health's hospitalisation policy with respect to persons with intellectual disability?
That's right. So hospitalisation of people with disability policy. There was also a number of years ago in response to the issues that have existed for some time about people with disability not having adequate support or the support that they need within hospital setting. Work was done to develop what was called a joint guideline between health and ADIC, Ageing, Disability and Home Care, but also applied to the non-government providers. And essentially what that joint guideline set out was, one, provided a template for a hospital support plan for both sides to use. So for disability services to fill out with, this is the critical information about the person's support needs, and this is, the key things that need to be put in place in a hospital setting for them. Hospital staff were then to use that to fill out the next bit, which was through discussion with the person with disability, the service provider and other relevant parties, families or others, to look at, okay, based on those support needs, what needs to be put in place for the individual, and to work out roles and responsibilities at that point. That joint guideline was rolled out by ADIC and also rolled out across health services, but wasn't mandatory for health services. And generally there was an evaluation done a couple of years ago that found really poor uptake in health services, also generally poor uptake in disability services. But that work to, at the point of presentation or the point of admission, to enable the person's needs to be understood and clearly communicated, and things put in place to help them to meet those needs is fundamental, but on many occasions you don't see that happening. There are, similar to what Lynn was saying before, there's a range of tools that exist both for disability providers and also for health providers that provide guidance around things that can be done, so reasonable adjustments that can be made, ways in which information can be clearly communicated to hospital staff about the key issues for the person and what supports that they need. Those tools, and we've referenced a number of them in our submission, are freely available, and I know the Agency for Clinical Innovation Intellectual Disability Network in Health has been responsible for developing a range of them and pulling them together to provide guidance to local health districts. But it's that challenge of the health needs of people with intellectual disability being recognised enough as a priority for that to be not just rolled out across health services, but critically rolled out, but also monitored. So compliance with that guidance and compliance with health policy mechanisms to be put in place to look at compliance with it, to look at, importantly, to look at the health outcomes of people with intellectual disability in hospital. I know Commissioners have heard already as part of the hearings some information about that, so I won't go into that in too much detail, but the need for there to be kind of performance indicators and outcomes measures associated with the access of people with intellectual disability to hospital and broader health services is so critical and isn't there at the moment. Okay. The other key bit, really quickly, is that discharge planning. So again, there are really good policies that exist in health around discharge planning, including specific reference to discharge planning for people with disability. But again, really variable practice on that front, and I know there's some examples in our submission and examples I know that Lynn's also had where they'll see examples of hospital ringing a disability service in the early hours of the morning to say we're discharging someone. That's not an insignificant thing for a disability service who may only have one staff there. They can't leave to be able to collect the person, but also it's what the policy and the guidance makes clear is, again, there's supposed to be that conversation about and an assessment by health about whether the person's needs can be met back at their original setting once they're discharged.
Can I just, you've phrased a number of things. I just want to seek Ms Porter's input on the use of hospital support plans and what your experience of that is conducting community visits, whether you see evidence of hospital support plans.
Mostly they are there. The quality is variable. And obviously I only see, I see the plans there, and then I might go to a follow-up visit and see a person's had an admission and ask how that has gone. I hear, even though it will say clearly in the hospital plan how the person should be managed, time and time again you hear of a person in hospital that needs support to be able to eat their meal, and the meal just is placed in front of them and then taken away because there's no support. And I know that the NDIS funding has to pay for the staffing when a person's in hospital, but it's variable, and I don't know if that could somehow be a master document that services, so that it's consistent and the information that's contained in the plan is consistent. And then it's the implementation. So it might say some really helpful things in there, but you need the resources that go with that. So communication aids and anything else need to be attached to that. So yes, for the most part, I see hospital plans now. Years ago, no, they weren't there, but they are there now. So everyone has a hospital plan. It's about the service provider informing the first responders, the ambulance, and to be able to provide the critical information that's necessary. And they go to the hospital with the person, and then once they're discharged, then it's handed over.
You don't visit residents in hospital when
No.
they're hospitalised, and nor do you have access to hospital records. Is that the case? Do disabilities...
It may be if there's obviously the discharge letters and things, anything that contains in the person's documentation at the group home, I have access to, and more often than not, it's got discharge notes or reports from the hospital admission.
Okay, and just on discharge, how effectively is that dealt with? Have you ever had instances where there's been a lack of information from the health service or a lack of planning, which has meant the person has had problems being taken back into care in their group home or had to be readmitted to hospital?
I have, where there's been no ownership. So staff will, there needs to be really clear discharge planning, and there needs to be a handover. It needs to be transitioned, and staff need to be made aware of what the person's needs are post-discharge, and they need to have adequate training. And I do see some good evidence of staff having to have particular training when a person's coming out. They might have a stoma, so that they need to know that the staff are able to support them. Does a community nurse need to come in? It's variable, and I apologise for that, but it shouldn't be variable. It should be the same across the board. But it's really dependent on the service provider having that communication with health, with the hospital.
At page 5 of your submission, Ms Mackenzie, you've said that official community visitors advise that there's a continuing misconception among hospital staff that disability accommodation settings are medical models staffed by nurses and other health practitioners. And so that's a common issue that's raised.
That's a common issue and a really, really long-standing issue. So that's been around for a long time.
Which predates the NDIS.
Predates the NDIS and is, I think, reflects the medical model that used to be reflective of disability support. But, I will say, despite a lot of evidence to the contrary, that perception continues to be there. So despite health services having a lot of contact with people that clearly aren't nursing staff, despite health policy indicating exactly that most of the residences are not, or most of the support staff are not nursing or health professionals, that perception is really persistent. And it affects things like discharge planning. So there's an assumption that the person can be discharged back home despite kind of a significant change in their health needs, because once they're discharged home they'll be supported by nurses, when in fact that's not the case. And as Lynn was mentioning, critical need for support staff to have really clear guidance around the support that's needed back at the group home, based on potentially changed needs during the hospital admission. There's been numerous examples where that information hasn't been adequately imparted to disability support staff, with adverse outcomes for people with disability, including things relating to swallowing issues, where the swallowing function of the person has declined during that hospital admission, but that hasn't been adequately conveyed to disability services staff. And
and you
Ms. Wright, we don't want to incur the wrath of Ms Eastman, so
yes,
perhaps another few minutes.
Yes, thank you. Chair, I just wanted to touch, if I could, on dental care, given that it's an issue that the Commission's interested in and looking at. I think, Ms Porter, you have some particular observations to make about access to dental care for residents in disability-supported accommodation.
I think that it's appalling, the access to, in particular, public dental system. Westmead dental, the waiting list is very long. The staff at the group home tend to not do good dental care, oral care with a person, especially if they're resistant to that, which mostly they are because they don't want something shoved into their mouth, so they're very resistant to that. I've seen oral hygienists be employed to deal with that very issue, to actually work with staff to assist them to know how to best provide oral care to a person, to look for any cavities or concerns, or is the person in pain, and then to facilitate access to, that you may be able to see a private dentist. There are a lot of dentists now that, not a lot, but there are dentists out there that have an interest in people with intellectual disability and treating them. A lot of people that live in supported accommodation have funds because the residual of their pension is not spent. They have tens of thousands of dollars that could be spent accessing a specialist dentist. But again, staff just say, well, they're on the waiting list for Westmead Dental, and what happened? And it's, oral care, our oral health is connected to our physical health.
Yes.
And again, it's just, it seems to be dismissed by support staff to say, well, they're on a waiting list and that's all we can do. They're not proactive, and they can be. They could try to get, at the very minimum, an oral hygienist, because I do know, and I know that sometimes I'll talk to residents and you can clearly smell that they've not had their teeth cleaned that day. And some staff just don't seem to consider that a concern. I tried, and that's all I'll do. The same as I think I raised in here too, and I know it's completely off issue, but recording weights for people with intellectual disability, critical to health if anything's emerging, if there is any concerns around their health. And people aren't being weighed for 2 years. People aren't seeing dentists for 2 years.
And you've seen some cases where residents have lost weight progressively over time because of an overarching health issue.
And they've had a
been
cancer
picked up
diagnosis,
because
yes.
weight hasn't been routinely done. Ms McKenzie, just finally, do you have anything you wish to add on the issue of dental care and access to dental care?
No, basically the broader visitors going into services have said consistent information to what Lynn's imparted, just really significant waiting lists for those specialist dental clinics, public dental clinics, inadequate kind of exploration of other options for individuals. And that applies also to people in assisted boarding houses. Can also be significant dental issues and also waiting long periods of time to access that health support.
Thank you very much, both of you, for your time this morning.
Ms Porter and Ms McKenzie, thank you very much for both your submission to the Commission and for coming and giving evidence today. Both have been very helpful. Thank you very much.
Thank
Thank you.
Ms Wright, shall we take a 15-minute adjournment?
Right.
The Royal Commission is adjourned. The Royal Commission has resumed.
Yes, Ms Eastman.
Commissioners, I understand from the evidence that was given just before the break that we need to formally tender the submission and mark that as Exhibit 4.26.
Thank you.
Thank you. Commissioners, we now have evidence from a witness who will have a pseudonym AAJ.
Sorry, Ms Eastman, there were 2 documents referred to by the last witness.
Now you're tricking me because I wasn't here. So I understand that the documents which would be found in...
I think they've probably been gathered together.
All right.
Yeah. There is a nodding that suggests that they've been
So I think
dealt
there's
with
2
together.
documents, but together they'll be marked Exhibit
Thank you.
4.26. All right, thank you for that.
Very
All
good.
right.
Has that got anything to do with?
That's got nothing to do with...
Nothing to do with you whatsoever. Would you mind taking either the oath or the affirmation as you wish? Thank you.
Do you solemnly and sincerely declare and affirm that the evidence which you shall give shall be the truth, the whole truth, and nothing but the truth? I do. I will.
Thank you very much. Ms Eastman will now ask you some questions.
So, Commissioners, our witness is subject to some directions made by the Royal Commission in relation to the pseudonym to be given to this witness, who'll be known as AAJ, and I'm going to call her Dr. J for the purpose of giving the evidence. If anyone needs a copy of the relevant orders, then arrangements can be made for those orders to be available.
Thank you.
So, AAJ, you have prepared a statement for the Royal Commission,
Yes, I have.
and it is dated the 8th of February this year.
Yes.
And you've read the submission and the contents are true and correct to the best of your knowledge and belief.
They are.
Now, I just want to check that we're picking you up in the microphone and that you can be heard.
Is that okay?
That's even better. Thank you very much.
And don't hesitate to speak nice and loudly.
Okay.
All right. Now, I'm calling you Dr. J because you are a qualified medical practitioner.
I am. I'm a specialist in palliative care. I'm a senior staff specialist, and I've been practicing as a specialist for over 20 years.
And over the past 20 years, you've developed an interest in the management of patients with intellectual disability, both within the field of palliative medicine and general medicine. Is that right?
That's right. When in my first specialist job, I worked purely in the community, so I saw quite a few people in group homes. I'm now a specialist in a teaching hospital, and obviously I see people through that domain. So I've seen people at home, and I've seen people in hospices, I've seen people in acute facilities, and I also do outpatient clinics. So they're the sort of, all the domains in health. I've worked in all of those.
Right. And for the purpose of the evidence for this Royal Commission, is it right, as you say in paragraph 12, that what you seek to do in this evidence is to provide a description of some of the poor decision-making that you have observed by clinicians looking after people with intellectual disability in a health system over the past 20 years?
Yes.
And you acknowledge that patients with intellectual disability have a life expectancy 20 years lower than their aged matched peers, and you welcome the opportunity to engage directly with the Royal Commissioners as to how patients with intellectual disability have been undertreated, mistreated, abused or ignored by the health system on occasions. Is that right?
That's correct.
I think you are guided by a saying that's recorded in paragraph 14, and that is, how a society treats its most vulnerable is always a measure of its humanity.
I think so. I think if we treat the weakest in society, we will always be treating people well.
And you have a particular concern about the experience of adults with intellectual disability, and the perspective from palliative care is that you often see adults with intellectual disability towards the end of their lives.
I think my experience has been that sometimes people are actually inappropriately referred too early to me, which goes against the grain in my specialty. We actually want people to be referred early so we can help them as much as possible. And so I'm frequently seeing people years before they die. But on several occasions, in the case of people with intellectual disabilities, they're referred to me before they've been offered any treatment for their, what is usually a cancer. And this, has greatly concerned me because, those patients have been able to have treatment with what we call, we obviously may have to modify that treatment, but it's often not even being considered. And if you've got someone with an intellectual disability, well, then they obviously don't realise that's the case. Or if they have a parent or guardian, they may have been told, well, this is too much for them. And there are times when treatment for a cancer with somebody with a disability may not be the right option in terms of active chemotherapy or radiotherapy. But there are times that they should be treated, and I've come across times when they haven't been, and this has been very concerning to me. So in reality, yes, I want to look after people with intellectual disabilities, but at the right time in the right place. I don't want them to be referred to me when other treatments might be appropriate. And the patients that have had treatment, I've continued to see them, but I have recommended that they have more active treatment.
Well, is it the case, and I think you deal with this in your statement, that often someone may present with a fairly advanced disease at the local emergency department, and if at that moment in time we look backwards, some of the underlying issues are first, how did a person come to a point of having an advanced disease with a presentation in emergency? That requires us to look back and ask the question, what was happening in terms of primary health care, both preventative care, regular checkups, access to GPs, access to a range of other allied health services. Is that right?
Yes, and I think the prior two ladies who gave evidence really spelt out a lot. They really sold the message that people are not always getting primary healthcare services. But I also think that you cannot have the onus completely on disability support workers to know what to do next. So, I feel that the current system of general practice is just very much a very quick in-out. Where I work, there's lots of bulk billing places. You'd be in and out in 5 minutes. And if I may give an example, a colleague of mine who's a GP in Adelaide said that she often goes to see someone who's seen several doctors very, very quickly, but no one spent the amount of time you need. You are going to need more time. I'm not going to say that this can be done in the same amount of time, but I don't think that general practice is looking after the needs of people with intellectual disabilities very well, because they are often very pushed for time, and also the whole issue of doing home visits. Some of these people will need home visits. It may be actually too difficult to get them to go to a surgery and stay there, but if GPs do that, they know they're losing money, so they don't do it.
Right.
Or they rarely do it. I shouldn't say they don't do it, it's uncommon.
So the approach that you've taken in your evidence is to provide some particular patient examples where you've been involved in the care of a patient that has come to you in a palliative care context.
Yep.
And you want to illustrate some of the issues that arise through the examples of the patients. So, Commissioners, this starts at paragraph 19 of Dr. J's statement. And we'll deal with case number 1. So a few years ago, a woman in her 60s came to the emergency department bleeding heavily from her cervix. There were some initial investigations done at the emergency level, And do you want to take up from here what happened?
Yes, she came in and she was bleeding so heavily that she went into an abnormal heart rhythm. She'd lost so much blood. And that's when the sort of disagreements started, because if a patient is new and not known to a previous service, they have to be admitted under somebody. And there were some disagreements about who she should be admitted under. And initially she was admitted under cardiology, but then it became clear that the cause for her abnormal heart rhythm was the bleeding cervix. So she should then be under a gynaecology, or specifically a gynaecology oncologist, so somebody who deals with cancers in women. And there was toing and froing, and she ended up being put in under a general gynaecologist, which wasn't really the right place. She really should have been under a cancer specialist, but nonetheless they were doing the right things. And she was going to go for a biopsy, and the notes, the person who came, somebody came to see her, and just we get a referral sheet. So if you're referred to another specialist, you get a little referral sheet, and on it just said social issues +++ for biopsy, then home.
So were you called in at some point in
I was
time?
called in when a colleague of mine was asked to see her because she was going to be sent home, and it was specifically stated that she must come back in under palliative care should she represent. Well, there's several issues with that, because she didn't want to go to a nursing home. She had a home. And a colleague of mine had just started. She was a junior specialist, and she said, I just don't feel right about this. I'm not sure about the decision making. And then, so I did go and see, and nobody had spoken to the GP. She obviously, it said mental age of 5.
So when you say that, and you deal with this in paragraph 22, you went to the notes and someone had documented that the woman who was in her 60s had a mental age of a 5-year-old.
Yes.
And you were surprised by this statement, and you queried whether or not the person who had written the statement may have had any experience or training in assessing an adult with intellectual disability.
No, I'm sure it was just a random statement saying she has a disability, an intellectual disability. But there was no looking at her old notes. No one had rang the GP. People said the number wasn't in the notes. So what I did is I changed the number. Sometimes the numbers are wrong, and if you change the number, and I got through to the GP by just changing the last digit of the phone number.
What happened when you spoke to her GP?
He said that he didn't see her that often, but despite being institutionalised for much of her life, she had been discharged to, she lived with somebody who was really, was a friend. He also had some problems, but somehow they had really managed to make this work. They lived in their home, they were happy, and so that's where she wanted to go back to. He told me what medication she was on. He didn't have, many people have been moved to southwest Sydney because of cheaper housing. There was actually no record of her earlier life.
But yeah, I think part of what you were able to find out was that this patient had been on antipsychotic medication for a number of years.
Yes.
And you say that might have been common for people who had been institutionalised in the 1950s and 60s if one had an intellectual disability. And so this then required managing some aspects of her treatment. So after speaking to the GP, finding about the medication, you say in the statement that there had to be some behavioural adaptations.
Well, we put her back on her medications because you wouldn't suddenly cease it. Then what the most important thing from my perspective in terms of managing her cervical cancer is what were we doing for it? And it's very well known that bleeding can be very well managed with radiation. So every cancer has its own staging, and for this stage of cancer, the treatment would either be radiotherapy alone or chemotherapy and radiation. And I've got the radiation department I work in, I think is very, very good. And they planned, once I said, I think, they were very, very happy to treat her. They thought that was very appropriate. And everyone was saying, that she won't make radiation, it'll be... Anyway, she went down every day, had about 5 minutes of radiation, kept still, and it actually went very, very smoothly.
And that resulted in the bleeding being under control?
Completely under control.
Which in turn meant that she was able to be discharged from the hospital?
Yeah, she went to a subacute facility in another part of our district, and she did quite well. She did in the end go to a nursing home because it was deemed that her physical health wasn't well enough for her to go home, but that was all done in a planned way, and met with her friend who she'd lived with for several years, and he just continued to visit her in the nursing home.
So lessons learned from this patient you set out in paragraph 26. So you say it's hard for you to understand why this lady was initially not offered any treatment for her cancer. She had some form of intellectual disability that had probably never been diagnosed, but she had managed well over the 20 years, living in the community with the help of her friend and an attentive GP. You think that if the doctors maybe had slowed down or taken time with the patient, then that extra time would have been vital, you say, for good decision making. And I take it by good decision making is really thinking about what appropriate options might be for this patient, given the nature of her disability, the extent of the cancer, and how any modifications could be made to ensure that the treatment was appropriate. Is that right?
I think that when patients go through the health system, most hospitals are very busy, and you go on a conveyor belt and you see this person, then you see that person, then you see the occupational therapist, then you get discharged home. But people with disabilities can't go on that conveyor belt in the same way. And not enough time, more time needs to be spent. Obviously, in terms of communication, in terms of planning, deciding what's appropriate. Like this woman didn't have standard treatment, but she had a modified treatment. And in fact, one of my colleagues from radiation, she had actually noted that this was the only patient not talked about at an MDT, and she followed it up because she wanted to know why one particular patient, because we all talk about every patient has to go through an MDT process, which is where a specialist from every discipline is there.
You might just have to explain what that process is.
Okay, so maybe 10 people in a room. So for cancer, it would be a medical oncologist, a radiation oncologist, a palliative care doctor, a surgeon, a radiologist, and you present all the information about that patient that you have, so all the images and the history, and you talk. So it's to talk about every new patient that comes through the service to make sure there's equity and that it's not a random doctor deciding to do this or to do that. So you sit there and you make a decision. It's all recorded, and so it's just for new patients to make sure there's some quality control in decision making. But the radiation oncologist I knew, who was interested in, who did gynecological oncology, noted that this woman was the only one that was not talked about at the meeting.
Can I turn now to case number 2?
Just before you get to case number 2, is it an inference from how you've described case 1 that if this person had not had an intellectual disability, the cancer would likely to have been picked up much earlier?
I don't know if she had screening. That it was a very late presentation, and most cervical tumours are picked up much earlier than that. So it is very likely that she wasn't screened. But I don't have evidence of that. I didn't ask the GP. He seemed to, he was very caring, and she may not have, as we talked about, she may not have agreed, but it's likely that she didn't have cervical screening that's available.
So turning to case number 2, so about 2 years ago you saw a new patient at the palliative care clinic. He was a man of about 40 years of age, and he also came to the clinic with advanced cancer. He had a mild to moderate intellectual disability, and he lived with his sister, who was also his carer. The sister had taken her brother to the GP several times over the course of a year because he had bleeding from what was described as a back passage. She was told numerous times, that's the sister, by the GP that the patient had hemorrhoids and there was no need for further investigations. So about a year later, the patient was found to have had extensive cancer in the liver, which had spread to his bowel, and the bleeding had been the first sign of the cancer being present. So you say, based on your professional experience, it would have been impossible for the GP to say for certain that the problem was related only to hemorrhoids, and you say every doctor should know that bleeding, as in this situation, needs further investigation to eliminate the possibility of cancer. So the sister felt that the matter hadn't been investigated because her brother had an intellectual disability, and it was then for the sister to have to tell her brother that he was likely to die soon. So, with respect to the observations that you made in relation to this patient and what should have been done before, and the influence of the patient's intellectual disability maybe masking some other symptoms, what opinions did you form?
Well, the fact was, just to slightly change it, that the bleeding would have been the source of the primary cancer, and then a year later, because it's not been investigated or treated, he's now got rampant disease and he's going to die. She told me she had persistently said to the GP, well, it might be something more than hemorrhoids, because obviously bleeding from the back passage is a common cause of bleeding. And so when it did turn out to be cancer, she was so upset with herself for not pushing it harder, or maybe gone to another GP, but she shouldn't have had to do that. She should have just been, and why wouldn't you investigate a 40-year-old with if bleeding settles down, you maybe leave it, but most doctors would be very keen to rule out a malignancy in that situation in a young person.
Right. Can I turn now to case number 3? So this is a very recent case, and is it the case it's an ongoing case? For you, this is a referral of a man who's 37 years old.
Oh, yes, yeah. Yes.
He has a background of intellectual disability, but he has a job, and you say, and is very content with his life. He lived at home and travelled widely with his parents. So he has had a diagnosis of a very rare skin tumour, is that right?
Yeah,
and he was referred to you by a haematologist who had decided not to offer this young man any treatment for his cancer. Right, so you then pick up the referral. What happens with this patient?
Well, this man, as you say, is a young man with a nasty tumour, which is a superficial spreading tumour that really you end up being covered in tumours. It's well known to not be curable, but treatment can chemotherapy can palliate it and keep it at bay. But the parents were told that, he wouldn't really be able to tolerate treatment. And I feel that decision was made without really knowing what was available, because there's various forms of chemotherapy. You can have gentle chemotherapy from which you get very few side effects. You can get aggressive chemotherapy, which is designed to, obviously, to try and cure you. And there's other treatments in between. And I felt really uncomfortable about this. I just didn't feel they really understood the sort of variation in treatment. You could have a more gentle treatment, if you like, than a more aggressive treatment. And I was put in a hard situation because this is a public health system where somebody's on call, that person goes and sees somebody, that's their decision, they call me, I don't agree with decision one, and I don't want to. And I felt there'd been very, very little discussion between the consultant and the parents, because the parents didn't want him involved in any complex decision making. So what I did is I asked someone else to see him.
You had to do a bit of engineering.
I engineered. I had to
get a second opinion.
I got a second opinion without offending person number one, by telling her and saying, this person, you may have a little bit more experience. And anyway, he did have a bit more experience. He saw the patient. The patients had some treatment, and in fact, a drug came on the market in this year, which is a new immunotherapy, which he's responded to really, really well. And he's, as I was told the other day, like a new man. So he's not just alive, he's a lot better. And I cannot prove it, but I really feel that first decision was made on the basis of him having an intellectual disability.
Case number 4. So recently you've become aware of a patient when a palliative care colleague wanted to discuss this particular case with you. The man has an intellectual disability and he required an indwelling catheter in order to urinate properly. Unfortunately, all the catheters over time had become infected and needed antibiotic treatment. So I think you note that a person can become unwell fairly quickly if there is a bladder infection. So the patient spent a period of time in the hospital, is that right? And together with some emergency presentations?
He'd come back.
What was the sequence?
When you have a catheter in, you always get infections. You can't get away, it just happens. So you end up, if it's after hours, coming into emergency, or you end up coming into emergency if you're very unwell. And he came in with a recurrent infection. Before, he'd always been treated and sent back to the group home. But on this occasion, a doctor working there decided that maybe he'd had enough, and he felt that his quality of life would be better if he was at home, which I do not agree with, because if you have an infection, you feel unwell, he doesn't have a palliative care diagnosis, the way to treat him is to give him more antibiotics. Now, this is an inconvenient thing for him, but it's a necessary thing. But on this occasion, it was decided without any discussion with family, or certainly not with the doctor that knew him, not with the manager at the home. The family were given a call to say he was going home, but they weren't clear what was going to happen. And he was sent home with a bottle of morphine.
Back to a group home?
Back to a group home.
And were there any instructions given as to the administration or use of the morphine?
I can't remember. The group home would not have been able to administer it because they're not registered nurses. And also you can't, if you are going to administer to get authority, it has to be in a Webster pack. It can't be a liquid like that, which can be opened and tampered with. So the group home get him back with a bottle of morphine and
What's the purpose of sending him back to a group home with a bottle of morphine?
Because some people equate palliative with morphine, which is not necessarily the case. I do not know. It just seemed to be, this person said they deserve the dignity to die or to continue. It's not clear. They said that he should stay at home. Here's the morphine. He didn't have pain, by the way.
Was it the case his patient's notes read something to the following effect? It is not in his best interest to have repeated emergency department presentations.
Yes.
And so you've interpreted that somebody has made a decision as to what is in the patient's best interest with respect to receiving antibiotics for a life-threatening infection. And your sense was that that decision was that he would die without further treatment. Is that right?
It's possible. Now, with people with intellectual disabilities, if there's a cause for an infection that can never be eradicated, then there may be a time when you don't treat them anymore. But this was a case of someone with a clear cause for the infection, a clear remedy, and so even if the person felt that it was inappropriate, that's the sort of thing you would get your family around, you would talk to them, you would try and ascertain the patient's wishes. You wouldn't, in the middle of the night, decide not to give someone antibiotics. It's the wrong place and the wrong time. And as it stood, he's got over that infection, and I've suggested that they try and put in a suprapubic catheter, which is much less likely to get infections. So that's another thing that may actually help with his readmissions.
You say at the time that you prepared this statement, this patient is stable in his group home, he's enjoyed Christmas with his family, and you feel that he's got a future. Is that right?
I feel that nothing really had changed in his life. He had just needed to have another infection treated. If there are other problems that come to light that will need treatment, the person who asked me to see him, I've said we don't actually need to see him. He's not needing palliative care. He's needing good primary general practice care.
Right. Case number 5. And this is where you want to give some examples of patients who you describe as being shunted in the system. Is that right? So this is an incident in 2018, and an adult palliative care ward looked after a 16-year-old boy with severe developmental delay and respiratory infections. So this young man was not your patient, but you discussed his case with a colleague. And the issue that arose here was that this boy was extremely unwell and he was on life support. And you say, but against the odds, he was weaned off his ventilator and then needed to go on to a ward for ongoing care. The issue was whether or not he could be managed in the paediatric ward. Is that right?
Yeah.
And you say that the paediatric ward would not accept him because they felt that his needs were too high for a paediatric ward. The adult respiratory ward would also not accept him for his care, and you weren't part of the conversation. But how did this situation end up being resolved for this 16-year-old young man?
Well, the paediatric ward said they couldn't do the suctioning. As I said, that wasn't my conversation, but they felt they couldn't manage him. The respiratory ward felt that was more an ethical thing. They didn't feel that it was necessarily appropriate because these issues obviously are very, very delicate, very finely balanced. And this young man was very unwell with chest infections, but the mother, her specific request was that he not die from a choking episode. She acknowledged that if his heart and lung gave out and or he developed overwhelming infection, so he wasn't actually going to be resuscitated, okay, but she had this specific request about suctioning him and not seeing him choke to death. And that needed our ward to agree to that set of care. He did actually need suctioning quite soon after admission, but continued to improve. And I mean, we actually didn't necessarily expect him to improve, but we did say we would follow this plan, which was at the request of his mother. and he got better. And he went home. He was home for a year, and just at the writing of this, he came back into hospital with another chest infection, but we haven't been asked to see him, so he's not an ongoing palliative care patient in the hospital.
So these 6 case studies that we've looked at, I think you would say are just examples of what you've seen in practice over the course of your 20 years, is that right?
And also I'd like to say I haven't seen as many people as I should do. I worked out last night with the incidence of intellectual disability being, say, 1% or just less than 1% in the population, times the number of people I see a year, times the number of years I've worked in practice, I should have seen at least 200, and I've not seen that many. I've seen quite a few, but also that is because people send people my way. I've become a little bit of a, if there's somebody in palliative care with a disability, I see them.
Now, autism was a particular topic that you wanted to address, and you've addressed this in some detail in your statement. You say at paragraph 50, autism needs special mention, and most clinicians do not appreciate the underlying cause of deterioration in behaviour of a patient who has autism or presents with autism. And not appreciating perhaps different responses to pain and a combination of problems raise some significant difficulties on occasions for patients with autism receiving the right care. So partly that could be diagnostic overshadowing, partly that could be having an understanding about the way in which behaviour might be indicative of pain or present other symptoms. Is that right?
Yes.
And you say in paragraph 52 that your personal and professional experience has led you to conclude that in terms of hospitalisation, there are virtually no services to support acutely unwell children, adolescents and adults with severe autism. So that's a pretty significant conclusion to reach. Can you assist the Royal Commission as to why and how you've reached that conclusion?
Well, I do have a child with severe autism, an intellectual disability and epilepsy. So on a personal level, I've had several presentations with my son to accident emergency. He also goes to a school for people with severe autism, and I've seen all the parents in a similar predicament to me. And I know there is nowhere to go if my son is agitated, and I might not know the cause for that. At the weekend it was a rolled ankle, but I didn't hear about that till Monday, so he was in severe pain and hence he was very distressed. And the times I have taken him the times he has been admitted, has been a very traumatic experience because there's no specific place. So there's a higher incidence of psychiatric problems. But my experience, and this was being told face to face to me, is that my son couldn't be admitted to the child psychiatric ward because his autism was too severe. And that I will never forget that. I was told if his autism was not coupled with an intellectual disability, he could be admitted, so he couldn't be admitted. And that was on New Year's Eve 2017.
You are a medical practitioner,
Yeah.
and you've had to take an advocate with you to secure his admission in emergency, is that right?
Yeah, because
why do you... So people might be watching this and say, well, at least the doctors should be able to navigate the system, a system that they know. Why did you need to take an advocate?
They say it's a behavioural problem without... Obviously it is a behavioural problem, but why is it a behavioural problem? And then then there is nowhere for them to go. In the end, the advocate came in and made it quite clear that he couldn't go home with me because he was going to be a danger to me in that heightened state. So I was told he couldn't be admitted to the child psychiatric ward. And so they did put him into a medical ward with a security guard. And, you know, obviously that's not the right thing to do, but they were trying to make sure everybody was safe. But the reason I'm saying we need proper beds that would actually accommodate a child with autism. So at his school, if he gets agitated, there's a room which I call a sensory room, so he can lie down, he can just relax, and generally speaking, you don't need any drugs. But the presence of a security guard for 3 weeks didn't help him.
Was he in hospital for 3 weeks?
Yeah, and the trouble is that there was a different, this is quite often the way specialists work. I don't work like this, my department doesn't, but it's quite common for a specialist to be on for a week and then it's the next one. So he had a rotating specialist, and the last one said, you know, well, he's got to go. And he had no idea that a respite home didn't have any medical personnel. So when he was more agitated, they pushed discharge more because they didn't know what to do.
So where did he end up? Did he come back home, or
he ended up
respite?
in a respite home for a couple of weeks, or no, maybe just a week before he came home. But even then, I was told, there was one point, 2 days before he left, I said he can't go to the respite home tomorrow because they're worried about another child there being aggressive towards him. And the paediatrician said, I've never heard of a child being aggressive to another child. I said, well, you're not moving in the same circles. And made a big fuss about that extra day just for my son's safety. He went there and then he came home.
I want to ask you now about some solutions, and these are informed by your personal experience, but also what you've observed in the health system over many years. If you need a moment, let me know.
It's okay.
The solutions you start to discuss at paragraph 64 of the statement, and I think you pose a very important question, and that is, what can the general health system in Australia do to treat children and adults with intellectual disability humanely and equitably? And so that simple question then informs the solutions that you think would make a difference. Is that right?
Yeah.
So first of all is education, and you say, go back to the beginning. The education of doctors and nurses needs to be overhauled in relation to training in intellectual disability. So part of the training, you say, is to develop the tools to look past the disability and not become trapped in the diagnostic overshadowing. Is that the first one? And the second is that doctors and nurses, you say, really need to understand that quality of life is subjective, and that patients with disabilities can lead active and contented lives. They need to reflect their attitudes, and that's the medical practitioners and nursing staff and others, I assume, may be biased due to their own expectations as to what a full life looks like. And you say, if we do not instill these values and reiterate ethical principles to young students, they will rarely develop these values and principles later in their professional life. Now, one might say, reading that evidence and listening to you, that's a very sad state of affairs.
It is. I worry for the future of my son and for other people with disabilities. I feel that I don't feel hospitals are safe for people with intellectual disabilities, especially when they're non-verbal. I've seen, if I might just digress, I once went into a local hospital and there was a man screaming loudly so that everyone in that ward could hear him, and there must have been at least 100 people around, and no one questioned it. And I said, what's wrong with him? And they just said, oh, that's the man with the disability. And I said, but there's got to be something wrong. That's a cry for help. And so no one did anything about it. So I rang the consultant up and I said, this isn't my patient. One of your patients is screaming at the top of his voice and everyone's just learnt to ignore it. Anyway, I called a support worker in. They calmed him down. I don't know what it was. My point is that everyone was happy, or everybody could just listen to that without acting on it, other than just saying he has a disability. So I do think we have to start very, very early on. We do work in a very fast-paced system, and I think that we don't stop and reflect enough. And that's maybe not just for, it's not always for people with disabilities, it may be other things as well, but doctors really know nothing. And I don't know what the undergraduate course is like. I didn't get any training whatsoever. There might be an occasional lecture, but there's certainly not enough. So you're trying to teach people when the horse has bolted and people are practicing, but it needs to be instilled when they're more malleable.
So you have noted that there are some excellent resources available, you say, and that includes the Intellectual Disability Mental Health Core Competency Framework, a manual for healthcare professionals, and that's been produced by the University of New South Wales together with New South Wales Health. So you'd like to see, and I think that's partly some of the work done by Professor Troller, who gave evidence
but
last week.
I wouldn't like to guess at how many people are aware of that training module. I think there needs to be mandatory training, like there is for respecting the difference, how to treat Aboriginal people when they come in the health service. We are given so many modules to do that unless it's mandatory, it won't be done. We're overloaded with things, so I think it's important enough to make it mandatory.
Other things that you mention as solutions are legislative change, and that it might be helpful for Australia to look at a model used in the UK with the UK Autism Act, is that right? And that sets out some legislative standards in relation to, in effect, doing an audit of whether or not a particular health system or other system addresses the rights and the needs of people with autism. So that's a suggestion you'd like someone to look at.
I'm a bit out of my league, but there's lots of lawyers in the room, so they can have a look at that.
Then you'd like to see some services that specialise in looking after patients with intellectual disability, and so addressing the need for specific clinics, not only in the cities but also in regional areas. One of the other issues that you raise, and I think you've talked about having to attend a hospital with an advocate, and that was a lawyer, wasn't it? So you have to take a lawyer to a hospital. Right, okay, well that might not necessarily be ideal, but you have talked about...
She was an advocate, she's also a lawyer, but she went in as an advocate.
Okay, but you talk about the role of advocates, and you say the development of a disability liaison role within hospitals to assess people with intellectual disability needs urgent consideration. So this is this way of being a bridge for people coming into an acute setting, that there's somebody who can assist, it's really like navigate through some of the systems, is that right?
Well, I learnt a couple of days ago that New South Wales is putting some money into intellectual disability health teams. But I think someone needs to be in the hospital, especially in a large hospital, or somebody to cover a few hospitals. But it's almost like to help that patient through, because everything's more difficult, everything's more prone to error. You're always having to deal with the NDIS because there's the argy-bargy about who should look after them, should it be, So someone who's just there as really an advocate.
To have that. You also address specifically palliative care. This is paragraph 74 to 76 of the statement. And so you'd like, I think, to see the healthcare system better address when and how a person with intellectual disability might find their way into palliative care. And is it fair to say that your view is that they can slip between the cracks without an advocate, and that they may come to your attention in circumstances that you've illustrated in some of the case studies where they don't really need to be managed at an end-of-life phase in palliative care if appropriate steps were taken earlier on. Is that right?
I just think there's a whole hidden community of people who are never seen by specialists, and most people come to me via specialty referral, not general practice referral. So it would be largely trying to find out where those people are in the community. And Julian Troller, myself, and some very clever people that deal with big data are going to track what services people are getting, because I just think they're not known about. They're just never getting far enough into the system to get the right referrals.
And particularly patients with intellectual disability in group homes is an area that you think requires some specific attention.
Well, something like 85% of people in group homes have an intellectual disability, so that's largely, group homes are made mainly for people with intellectual disabilities, and getting them to interface well with primary health care is a challenge.
Now, you say in your statement this hasn't been an easy statement to make, and but you felt it's very important for you to give evidence from the perspective of somebody who works within the health system. I wonder if you want to read paragraph 78 and 79 to the final two paragraphs of your statement. I think you reading them will be a little more powerful than me trying to summarise what you say there.
I was worried about coming. I'm the breadwinner for my three children, and I didn't do this easily and not without checking my statement several hundred times. But the last statement, my statement may shock those who read it, as they may not expect the incidents I have described to occur in a developed country such as Australia. Sadly, it is because people with an intellectual disability may not understand they are receiving inadequate care, nor have the ability to report it. Even if they are able to report instances of poor care, they will not have the higher cognitive function to advocate for themselves. Patients with an intellectual disability face a profound struggle within the healthcare system from the moment they are born to the moment they die. As the former Chief of Army, David Morrison, famously said, "The standard you walk past is the standard you accept." We desperately need healthcare professionals to stop walking past patients with an intellectual disability. They and their families deserve so much more.
Dr. J, thank you very much for your evidence. The Royal Commissioners may have questions.
Thank you very much.
Thank you.
I would much prefer to thank you by your proper name, but I understand why you've preferred not to use that. Thank you so much for your statement and the care you took in preparing it and coming and giving your evidence today.
It's a
Thank
pleasure.
you very much.
Thank you.
Commissioners, AAJ's statement is found in Part A of the tender bundle behind tab 39. If I could formally tender that and be marked as Exhibit 4.24. So, Commissioners, I know we're not really stuck to time, and my apologies. I thought it was important that you heard all of AAJ's evidence, but if that's a convenient time to adjourn, I'll check with those who deal with the arrangements for the Royal Commission, but maybe if we're able to have a slightly shorter lunch adjournment and then resume in 45 minutes.
So we'll resume at 1:30.
Thank you.
Yes, thank you very much. We'll adjourn till 1:30.
The Royal Commission is adjourned.
The Royal Commission is resumed.
Yes, Ms Eastman.
Commissioners, the next witness is Jane Lehman, who you'll see is sitting and ready to take the oath or affirmation.
Ms Lehman, if you'd be good enough to take the oath, thank you.
Yeah.
The affirmation is what you prefer.
Yes, please.
Do you solemnly and sincerely declare and affirm that the evidence which you shall give shall be the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
Thank you, and thank you for coming today to give evidence. Ms Eastman will ask you some questions.
So, Commissioners, a copy of Ms Lehman's statement can be found in Part A of the tender bundle behind tab 40, and there are some accompanying documents that are reproduced at tabs 41 through to 43, and the evidence will become Exhibit 4.25 in due course.
Thank you.
So, you are Jane Ann Lehman.
I am.
And you are a diabetes nurse specialist, but also a director of a business in relation to diabetes education, is that right?
Yes.
And you've made a statement for the Royal Commission on the 13th of February this year.
Yes.
And there are two corrections that you want to make to the statement. They're not so much corrections, but just clarifications and additions, is that right?
Yes.
So the first is to paragraph 6.
Yes.
And you'd like that paragraph to read as follows. In 1988, I graduated with a Bachelor of Nursing, majoring in education at Flinders University of South Australia, and published the first of many peer review articles in 1992. And then the rest of the sentence
Yes,
is
thank you.
fine. So that's the additional words after the word published.
Yes.
To add the first of many. Is that right?
Mm-hmm.
And the next amendment is to paragraph 19 on page 4. And that first sentence should read as follows. We realised when Sarah was 11 months old, she had a 65-minute seizure at Victor Harbour during holidays, that we were in uncharted waters with her health. So that's the addition of the words after Sarah. The words was 11 months old.
And if you could add and
Right.
had a
Okay.
65-minute seizure.
We'll add that in. With those just clarifications, the contents of the statement are true and correct to the best of your knowledge
Yes.
and belief. All right. Now, Ms Lehman, I think we might start in this way. When you came to give your evidence and prepare a statement for the Royal Commission, you wanted to talk about your daughter Sarah's life and her experience with the health system and your experience with the health system. And Sarah passed away between Christmas and New Year, just before, a couple of days before her 26th birthday, is that right?
Yep.
And notwithstanding that very significant loss to you and your family, for which, on behalf of the Royal Commission, I express our deepest sympathy and condolence,
Thanks.
you wanted to give your statement.
Yes.
And I think many people have said to you, are you sure you want to make a statement to the Royal Commission and give evidence? Is that right?
I think more people have asked me that than are you providing evidence?
But you have decided that this is particularly important for you at this time.
Yes, and I've
this
been Sarah's
hearing.
voice and will continue to be.
And so even after Sarah's passing, you want to make sure that her voice is heard. And also your own experience as both her carer and advocate
And of her family.
over the course of her life. Right. So can I start a little bit with you, because you come to look at these issues from a perspective of experience in the health sector yourself. So in 1984 you graduated from Flinders University with a diploma of applied science in nursing, and that in your early stages of your career you worked as a registered nurse at the Flinders Medical Centre, is that right?
Mm-hmm.
And over time you've developed a particular expertise and specialty in the area of diabetes, and you're no longer practising as a clinical registered nurse, is that
No,
right?
I am.
You still have that, you still practice?
Yes, so I have my own clinics as well.
Right. But you have become one of the leading credentialed diabetes educators in the country in your capacity as a nurse, is that right?
Yeah.
So, you've set out in the statement some detail about your history and also the nature of the work that you're doing. And your husband is also a general practitioner, is that right?
Yes, he is.
And so from time to time he's had to step in and manage the care of your daughter Sarah, is that right? So you have 3 children, 3 girls. Your eldest daughter, Rebecca, was born in November 1991 and she lives in Sydney and she's a scientist, is she?
She's doing her postdoctoral work at the moment.
Okay. Your second daughter is Sarah and she was born in January 1994. And your youngest daughter, Charlotte, was born in 1999 and she still lives with you, is that right?
Yes, and she starts nursing on Monday.
Starts nursing?
As a student nurse.
Okay.
Yay.
So, the statement that you want to give to the Royal Commission and your evidence this afternoon is to talk about the experience you had accessing healthcare and services for Sarah during her life. And we wanted to start by perhaps getting a little sense about Sarah and who she was. And if at any time you want me to jump in and read any part of the statement, let me know. But I know that you can speak about Sarah very powerfully. And we also have some photographs. And at an appropriate time, and if or not, let me know if you'd like us to put up some of the photos of Sarah.
Yeah.
So tell us about Sarah.
So Sarah was my middle daughter, and I do remember when she was about 4 months old, sitting outside on a rug, and my 2 little girls were there, and thinking I was the luckiest woman in the world. And that changed a little bit later, because the trouble with Dravet's is that these children start on medications for their seizures so early. And so my initial response when I was asked this, when we were doing this, was I'm not sure what Sarah was like, because her behaviour and herself was always influenced by her medications. But I did read something that was lovely that someone had sent, and it was about the fact that Sarah was beautiful. She was beautiful looking, and she came to the world with a lot of challenges for which she relied on everybody around her to help her engage like her sisters could without that help. And Sarah could oscillate between being grumpy and head down to then being laughing her head off, and everybody would laugh with her. And she had, her toys were her friends. Because she was developmentally younger, she trusted them. They couldn't hurt her. They were unconditional in their love, and same with her books and videos. So Sarah loved the Wiggles. I was a bit worried for the Wiggle when he had his health issues. It was a few days after Sarah's death.
She's the old Wiggles, isn't she? Not
yeah,
the
I
new
thought
Wiggles.
she might have wanted him to come with her, but fortunately he's still on this earth.
Right.
So she loved the original Wiggles. She would talk to them, same with all the ABC characters and things. And so she was very much, my husband coined the phrase, she had an enchanted life. And she loved Snow White and the Seven Dwarfs, and lived her life really around those characters in many ways, which is what we got to enjoy with her as well. So she was a complicated person because of her communication issues. She could only communicate via her behaviour, and Dravet's has along with it a lot of oppositional behaviour because of the communication issues. She had to use other ways to communicate.
Right. So just to help the Royal Commission understand about Dravet's and that diagnosis, as you say, when she was about 4 months old, this was a time where you said, I've got these 2 beautiful girls. But this was the first time when she was about 4 months old that you noticed that she'd had a seizure, is that right?
Yeah, so she was in her bassinet, and had a seizure.
And then there was a very significant seizure when she was 11 months old. So this is the little matter that we just added into paragraph 19.
Yeah.
And you were on holidays at the time, and you remember that you had to drive her to the emergency. And then from the emergency, I think, in the Victor Harbour area, she then had to be retrieved by helicopter and taken to the Flinders Medical Centre. And that's where you worked at the time.
So I was actually having a holiday before going back after my maternity leave, and the 65-minute seizure landed us in ICU, yes, in that hospital, but we were very lucky that someone saw us coming in. The doctor was just leaving, and being a country hospital, we were very fortunate to have that doctor realise there was something wrong, turned around and came back. And it's often the case for those of us who are health professionals, we knew him as well. And so, yes, that was life-changing.
But she didn't receive a clear diagnosis until she was 11 years old. And
No.
why was that the case?
So Dravet syndrome was only identified really later in the 80s, 90s, and so there has not been widespread testing. A lot of it initially was research, under research arm, and so when they first suggested, we actually think our health professionals were a bit in denial around her condition.
Was there a thought that maybe she had a form of epilepsy?
They actually were saying, the neurologist was saying she had febrile convulsions.
Right.
And we knew that it was more than that, just from what we were seeing. And we were describing it one day, she had a seizure in the neurologist's rooms. What's interesting about neurologists is they haven't always seen a lot of seizures, because they see people after. And so this was the first one he'd had in his rooms, and he'd just finished saying, yes, it's febrile convulsions. She starts fitting, we hold off the Valium, and he says, I think we might revise that diagnosis.
Okay. So, do you want me to put the photos of
Yes,
Sarah
please.
up?
Yeah.
Okay, we might do that now. All right, so you might sort of see just...
I know,
on
I
the
can't
screen.
look.
Okay, all right. So I've put them up. Can I describe them then? So the photos that you've provided to the Royal Commission include a photo of Sarah when she was just a little toddler, is that right?
Yeah.
And then you've got a photo of her in her favourite yellow wheelchair. And so we can see that she's received a visit from Snow White.
That was when her wish was granted with Make-A-Wish.
Okay. And there's a photo in the middle of the page where she's in a hospital bed. And this is going to be something that we'll talk about in a moment in terms of that occasion. And she's got a really big beaming smile. And this was because this is an example where you had to intervene and find out what was wrong. And we'll come to this later, but she'd bitten her tongue. And then finally you worked out what the problem was.
Yeah, and she'd
You were
had
able to
12
come.
seizures and no one had checked in her mouth. God bless them.
And did you say that you put a bit of a filter on this one?
That one. I was playing around with filters to make her laugh, and just by chance they ended up being a beautiful photo. There were others with bunny ears.
Okay.
But I thought they weren't appropriate for the commission. Or maybe so.
And then you've got some photos of yourself and your husband with Sarah, and also some photos with her sisters.
Yeah.
And the photos, she's holding some of her precious toys, is that right?
Yeah.
And these are relatively recent photos.
Yes, they were. I think those ones were about a year ago because they were a wedding of our god family.
Okay. Thank you for sharing the photos.
Yeah,
with
that's
us.
all right.
So I want to ask you a little bit about Sarah's communication, because one of the features of your evidence is that it's Sarah's ability to communicate and the way in which you had to learn and those around her had to learn what her communications needs, a very important thing that you think the Royal Commission should be aware of.
Yes.
So paragraph 27, can you explain to us what were Sarah's communication challenges and what was her mode of communication, particularly around her health issues or if she was feeling unwell?
So Sarah didn't have the capacity to have a conversation like other people. She had to use practiced sentences that she had picked up when she was younger that she would then place a meaning on. So it's called echolalia. And so as a historian, if you like, telling someone about her health, she could not do any of that. She also couldn't really provide any input around her pain. I only remember her having a headache once in her life. And that's because I think the seizure medications impact on pain perception, and Sarah's pain threshold was very high, so much so that she could walk from one end of Adelaide Women's and Children's Hospital day 6 after a spinal fusion to the other, and that's unheard of. Usually you can only hobble around a bed. So you couldn't trust in some ways what she was saying, but she was communicating. And so things like she would say, not a doctor, or eat doctor, meaning it wasn't necessarily about a doctor. It meant that she was really uncomfortable. So one of the positives of the NDIS for us, and I had, I guess, what I would call an NDIS smile moment, and I think we need to be celebrating those smile moments because lots of people are getting them when they see the impact of those services doing something positive for your person. And it was when I started understanding Sarah's communication. And so last year we had spent a lot of time working on that. Her face wouldn't have the same expression as what my other children, for example, or myself would have. And so you really had to focus on the context of where she was, how she was reacting. So within a health context, that makes it challenging, especially around picking up symptoms, because it could be that her behaviour changed rather than talking about a sore tummy. And you had to be very vigilant with someone with a high pain threshold. Pain is there to alert you to an issue, but if you lose that, then your first line of defence. So she could have easily had a burst appendix, for example, before it would have been operated on.
Okay. So you deal with Sarah's living arrangements, and she lived with you and your husband till she was about 19, and in 2013 she was placed in emergency respite care, is that right? By this stage she had completed school?
Yes, and I think that was part of the problem, is that when children who are, I guess, lower functioning leave school, quite often the final years of school have been problematic in that they're just being babysat. And then they leave school and guess who they come back to? Mum.
Okay.
And so equally with her behavioural stuff and being scared of moving from one thing to another, she'd also been physically abused at her school, being pulled from one classroom to another by her hands and legs. And so there was a fear for Sarah that people will hurt her.
So it meant a very difficult decision, didn't it, for Sarah to leave home, and she went to live in a group home, is that right?
So I have a problem with the word group home. I think if we're going to talk about accessibility, and sorry to do this.
No, please.
But it was her home for that amount of time. And if people are living in a group set up like uni students, we don't call it a group home.
That's very true.
So we need to be careful how we use that term because it immediately disables it. So I think she moved out because this was the only place she could go to. We had to essentially make her homeless in order for her to leave home when I had hit the wall from having had lots of input from the special behaviour unit. I had nothing else. I just couldn't do another second. And so she went to live in a place which was actually a respite house.
Right.
So not appropriate at all, and it was an hour away. And what's meant to be an emergency housing option, she was there for 2 years.
Right. You say in the statement, though, that she developed good relationships with a core group of her support workers, and she had a roommate who did things with Sarah, such as colouring in, painting nails, hair.
So that's when she moved to her
is that later on?
house. So after the 2 years in emergency housing, there were people coming and going within that service because they were there for a respite service. And then she eventually got a house which she shared with another girl until she died, who had also an intellectual disability, in a small group of little homes.
Right. Can I turn now to what quality healthcare looked like for Sarah? And you say in paragraph 38 that quality healthcare for Sarah was one that was delivered with respect, an open mind, and where Sarah was the centre of everything. And it was enhanced by health professionals who were able to use their knowledge and skills around the causes of intellectual disability and the conditions associated with it. So critically, it was very adaptive and non-judgmental, is that right? And I think you say in your statement that there are some examples that you'd like to talk about good quality healthcare for Sarah, and one was the relationship with her GP when she lived in the supported accommodation. So you found a GP who understood Sarah and her needs, and what was it about the way in which the GP engaged with Sarah that you say has the qualities of good healthcare?
It was around the fact that she respected the role that we had. Now, remembering my husband's a GP and I'm a nurse, and so we had to have a much higher involvement in her healthcare, because at times it would take 2 hours for Sarah to decide to move from the floor into the car. So I couldn't get her to appointments or anything. The GP I found was working in a clinic where I was providing a diabetes service for people with intellectual disability as well. And so she involved us. She was thorough. So she had a lot of experience with looking for the cause of issues. She did the annual screening using, I think she was using the CHAP tool.
CHAP tool. So just pausing there, the Royal Commission heard some evidence yesterday from Professor Lennox, who developed the CHAP tool, and you've referred to the CHAP tool in paragraph 125 of your statement as well as a helpful model that general practitioners can use. So this is the annual health assessment.
Yes.
So Sarah's GP used that tool.
Which is more detailed than the one that's available with Medicare with the intellectual disability annual review things. And it meant that the support workers and ourselves could have input into that before she went to the doctor. So it consolidates that group approach of information gathering and provides much richer information. The other thing is that she would organise bloods and referrals and things that were appropriate.
So coordinate. The other thing you identify as part of good quality healthcare is tools that can assist. And you have identified in your statement that you have developed some tools for people with low literacy, so picture-based resources. And this comes to the incident that's the subject matter of the photo. So you say in paragraph 54 that during a hospital admission last year, Sarah bit her tongue, which caused considerable pain and damage to her tongue, and her behaviour and the seizures were very problematic. But you created a low literacy resource to communicate with Sarah for the source of her pain, and you've included that in the material. I don't think we need that to come up on the screen, but commissioners will see that behind tab 42 in part A of the tender bundle. And so it was using a series of photos and pictures to help you identify what might be the source of the problem. And that meant being slow, patient,
Yeah.
and giving Sarah the time to be able to tell you what was wrong.
And it also meant being a clinician to pick up the problem. So the difficulty is that it was clear that the doctors were out of their capacity to be able to care for her, because no one, even though she came in after 12, she had 12 seizures at least, and no one looked in her mouth. And so there's a lack of assessment other than what's right in front of people. So if you don't pick up these other issues that are not going to get identified maybe till later, firstly, you can't get pain relief in place. And equally, Sarah was not happy. She was clearly in some pain. She'd stopped eating and drinking. No one had started a drip yet. And when I said, I think, mate, did they use a tube in her mouth or something? Like, I thought they might have damaged her throat with a tube when she was having a seizure or something. And it was the bitten mouth. So because no one had looked, and then she wouldn't let them, and I don't think they would have looked in her mouth anyway. And so I said, okay, give me a torch. I'm going to have a look and see what it is. So I had a look, and it was very obvious. Both sides of her tongue were mangled, and we all know what a small ulcer on a tongue feels like. But if you've got it both sides, that's very, very painful. And so I said, okay, we need to get fluids in, and we need to get pain relief on board, and I'm going to have to explain this to Sarah. So that picture was inadvertently after I had explained it to her, but I then also went home and developed, just with board maker symbols, a thing saying, you know, Sarah had bitten her tongue, mummy knows it's sore, we can do something now to help, we can stop the pain, and we know now it's okay. And so that smiling face was because she understood that I knew, or at least someone knew, and we could now do something about it, and it was very obvious it was linked to that communication.
The other tool that you have found to be very helpful for Sarah is a set of documents that you call the hospital passport. And Commissioners, again, I don't need this to come up, but a copy of the hospital passport is behind tab 43 in Part A of the tender bundle. And the passport is a document that sets out all of Sarah's health information, but also a guide to communication, her likes, her dislikes. It gives you a sense of who are the family members. And so it gives you a pretty good overview about Sarah. So she used this passport in working with her GP, is that right?
And also the dentist. The thing with people who can't communicate is no one gets to hear their voice in the first person. And so for years I'd been developing different things that were written in the first person, and it's very interesting when you do that, the different reaction the health professionals have when they come in. And this version was one I found via the disability organisation, and it's from the UK, which I've put the reference in.
The Life Raft, and in your statement you've got a reference to the website for the Life.
And it's also the way it's written. You have to write it in the first person in simple language because people are reading things quickly as health professionals. And so to make it easier for them to understand also means that you can read it to the person. So you might think it's weird that I say things like mummy knows, but with Sarah with echolalia, we had to talk like that for her to understand and didn't misinterpret words. It was just the way that worked the best. So that document changed things, and we got told in that last hospitalisation both in the resus, the acute medical unit and also the ward. They wished everybody with intellectual disability came in with that information.
And that's something you prepared yourself over a period of time, is that right?
Yeah, so I would write a lot of the information and then the organisation would take some of that. I mean, one good thing about Sarah going into care was that I had a chance to write all of what I knew about Sarah. I got to write that down. So if I died, it was all there. I actually felt I wouldn't be leaving her without her having, and her sisters having the benefit of that knowledge.
Do you know of any similar document that is available in Australia or in use in Australia?
I'm not sure what happens here in New South Wales. They've done some work in this area. The reason the UK has progressed so much is because of their Equality Act that was put into play in 2010. And that has meant that all health services, and there's 8 other groups of services, they have to be accessible to people with intellectual disability, physical disability, around age, gender. So what that did was change things overnight, because there was a responsibility for every service to be accessible in its communication to people with intellectual disability, and that's what has fueled the UK's positive movement in the development of these sorts of resources, I believe. And one of the recommendations I am making to the Commission in this hearing is that that's what we need in Australia. We've got discrimination acts, we've all signed the UN Convention. I heard some of the stories before. You've heard how hard it is for health professionals to get people with intellectual disability. Even the NDIS Quality and Safety Framework, they don't get people with intellectual disability either. So if we have a law that puts the onus on all public and private services, and just talk about health services in this moment, one, we start to open up access to private health insurance for people with intellectual disability. There was no point in having private health insurance for Sarah because we would have been told, no, we won't admit her. She needs too much care. So we're going to need an overarching legal framework that brings the voice of people to a point where it's just taken as being appropriate business to have accessibility for people with intellectual disability. So you will see a plethora of things being produced. In South Australia, we have just been remodelling our health service for people with intellectual disability, and I've been involved with that quite actively. I think it'll come out in the recommendations that we will be introducing a health passport in South Australia for people. And, you know, we now have ways of doing these things in a coordinated manner. So I'll talk about that more maybe when we talk about the solutions. So there may well be more out there, but we don't know everyone or everything. This is part of the problem. There's pockets of things happening. We have to look over the world as to what's happening, not just in our backyard, for the positive things we can then adopt, I think.
So the next part of your statement deals with some of the barriers in terms of communication and listening to parents, and some of this comes back to the incident about you identifying the injury to Sarah's tongue. But if we take that incident in terms of what you had to do to address the fact that she was becoming dehydrated and she wasn't swallowing, can I ask you to jump to paragraph 86 of the statement? And on this occasion, you are saying to the Royal Commission that during this incident of hospitalisation, the support workers were also essential for Sarah, And you say in paragraph 86, on day 6 of the hospitalisation, Sarah's support workers were told by their disability support organisation that they could no longer provide support in the hospital, and this was due to the NDIA staff telling them that Sarah's NDIS supported independent living funding couldn't be used to pay the staff while she was in hospital. So this is a big issue for you, isn't it? So you contacted the NDIA and you were told that Sarah's funding could be used to pay for support staff in hospital. And so you wanted to have some clarification around this issue, and you say in paragraph 89 there is a desperate need for clarification on who pays for support workers to provide support while a person is in hospital. So on this, could you help the Royal Commission have an understanding about the importance of the support workers while someone's in hospital? Because the assumption might be it's not necessary, you've got all of the doctors, nurses and all of the support that come with being in hospital during a hospital stay. Why would you need to also have your support workers? So can you help us understand how this is critical in your view to the delivery of good healthcare outcomes?
So Sarah would not let the nurses or the doctors touch her. And so even though the hospital passport is a great tool, it's not the answer. So hence why it was me who did the assessment and things like that. This was the first admission where we'd been able to use our support workers. And because we had to have an urgent review in order to get more funding through NDIS for the ongoing budget to pay for the extra care, I had, without realising that the organisation was getting involved, asking for clarification about the funding in hospital, I had done that separately. And so I was quite shocked when they told me that they were being pulled out. And I guess we'd had previous public hospitalisations where, as usual, it was always me doing all of the support. This time having the support workers meant that Sarah was showered. Now, she probably wouldn't have been showered. They were able to make her feel more at ease. They were able to assess and give more information around the fact she wasn't eating or drinking. And in fact, that hospitalisation, she lost a lot of weight that no one even realised, they just weren't even listening to. They were also able to make me feel more reassured that she would be safe. So when she moved from the acute medical to the ward, she was in a ward with people who'd all had strokes. So there was no one in that room who could speak. And then they were removing the one-on-one nursing care as well. So the support workers or I were there all the time. Once they were talking about that, I said, no, you can't. She's too vulnerable. She could try and get out of bed and fall out. She doesn't know how to push a button. If someone approached her, she wouldn't know how to stop them from harming her. You have a duty of care to provide her with ongoing supervision medically at the moment. She's just had 12 seizures and that would not be safe. And so they got the nursing, head of nursing at that time up. And so what we did was had her in a room with 3 other highly dependent people, and they had one nurse in the room. So we were able to negotiate the health side of it, which is different to the disability. So even with that extra support, she needed her people there who knew her. She can't communicate. So that was all fine. When I'd rung to get the emergency review of her plan, no one told me that it would actually take a number of weeks or even a month, firstly. So there's a huge deficit in being able to get an emergency review in hospital. I happened to call our Health and Wellness Minister's advisor and said, this is what's happening. Can you tell me what the funding situation is? And they said, no, it's been a problem ongoing. We don't know. And I said, how can you not know? Like, it must be someone's responsibility. So there hasn't been, it seems to me, a decision made on one level, maybe a hold up in the COAG load of things, as to who pays for support workers. Now, my thinking is that she had NDIS monies for disability support that would have been provided if she was not in hospital. Why can't they just give that in hospital when it's not health support, it's disability support? Why was I getting different information to what the provider was getting, and why was my voice not listened to in another call being made to question that?
So this issue about, which the Royal Commission's heard, about the integration of health and disability services, is that the disability services shouldn't stop at the door of a hospital, is that right?
Well, the person doesn't.
Even
the person walks into the hospital, they still can't talk unless something magic happens through A&E. They still can't talk. They still can't tell someone if they're in pain. They still can't, eat their dinner on their own.
Even when Sarah died, this issue for you about communication remains an important issue, is that right? So, because Sarah died in the care of a disability support organisation, there was an obligation to report her death to the NDIS Quality and Safeguards Commission, and they had to be done within 24 hours, and a further update provided in 5 days. And we're now getting close towards the end of February, and you haven't had any contact from the Quality and Safeguards Commission, and no request from the Commission for any information related to her death and what you should do in following her death in terms of the arrangements that should be made. Is that right? And so I think when you get to your recommendations, you talk about bereavement and grief counselling and a bereavement package from the NDIS as well. But just touching on this, and then we'll turn to the impacts and, more importantly, all of the recommendations that you want to make. I don't want to overlook that at all. But what did you want to say about your experience of a family member who's had a very recent death and still trying to sort out collecting the right information?
It dawned on me when I'd heard a number of times that the service had to provide notification within 24 hours and then 5 hours. Now, remembering I'm an NDIS provider, so I'm aware of the quality and safety framework. And I thought, okay, well, why haven't they asked me? Why hasn't anyone asked me about her death? Because if a disability organisation is providing the notification of what's happened, how does anyone know that it's accurate? We're not safeguarding them at all. And death is actually one of the biggest triggers for looking into what's happening around that person. Now, I also happen to be on the advisory board of the Community Visitors Scheme in South Australia. And we've had, as soon as the Quality and Safety Commission's legislation came in, immediately plans were put in place for the rolling back of the role of CVS in the review of what's happening with people with intellectual disability. So I've seen a rollback of that, and I felt safe when the CVS were visiting. The other thing is that if we're still getting conflicting information and we don't have a safety and quality framework that's sophisticated enough yet to capture the experiences of people with intellectual disability. For example, how do you make a report? An email? Phone call? Well, Sarah couldn't do either of those things. And I asked someone from NDIS Commission the other day, so what are your plans around making it accessible for people with an intellectual disability to be able to give feedback on their concerns? I think they just looked at me a bit stunned. Well, the Community Visitors Scheme is doing that, but we've had it rolled back. So why would you go and reinvent something new which isn't even on the radar, I might add, of the NDIS Commission, and use what's already working and accepted and successfully picking up. Those people are the eyes of quality standards. At the moment, there's not even a forum being held for people with intellectual disability to come and talk about what's going on with their quality and safety of their services. So it's inaccessible. Even the service that is designed specifically for the needs of people with intellectual disability, the largest group within that service, they are not providing an accessible way for them to complain.
So this is one of the areas that you want to say needs some change or some careful attention, is that right?
Yeah, and it also links with the stuff around death. You know, you can't have only the organisation being asked. I've provided and saved the country thousands and thousands of dollars in care. I've been there. I had to become basically an advocate in order to be able to talk to CEOs and ministers and influence their thinking and have them round my kitchen table for what we called kitchen cabinets in order to discuss and explore issues with the impact of change. I've done that all willingly. But if they don't get it right, I'm going to also be the one pricking their side.
All right. In your statement, you deal in some detail of the impact of Sarah's disability, but also her recent passing on you, your husband, and Rebecca and Charlotte, is that right? The impact's been profound. It's affected your health. It's affected your decisions about your own employment and the work that you do. It's affected decisions about such small things as to whether you and your husband can take holidays. But you're not grizzling about that. You're just saying that to understand the impact of Sarah and how complex her needs have been, that it has a ripple effect and a fairly significant one on the whole of the family. Is that right?
Even as a family, when we would go out, the staring that you get when your child is in a wheelchair and she looks like Sarah, carrying Big Bird and Wiggles, and, you know, the scrutiny that you get as a family is immense. And people would actually stand in front, you would probably have this experience if you use a wheelchair, mouth open. And I'm not talking just children, I'm talking grandmas. And it's like, and you think, okay, well, I know you're processing this, but could you close your mouth at least? Because it's actually very rude. So my daughters would come up with lots of ways to manage those situations to get the power back a little bit.
When Sarah died, you said to your daughters, we are strong women. Sarah has made us strong, and I hope that part of the legacy that she's left us is this. I hope those words pop into their heads when they face difficult situations in the future, and you know it will for you. But you say Sarah taught you and your family how to be patient, how to listen, how to watch for clues during conversations. And so this is a skill that you've found when you've been her, I think, nurse, physician, advocate, ministerial advisor, as you describe in the statement, that you've learnt a lot from Sarah. So it's not, the impact is not entirely negative, is it?
I'm a better clinician. I'm a much better health professional for having had Sarah teach me. And that's why I developed the services for diabetes around people with intellectual disability. We have to stop discriminating against these people, and we don't even know when we're doing it.
All right. So can I turn to the suggestions for change? So training and education is something that you identify. Commissioners, this starts at paragraph 110. And do you think that if there is greater training, greater knowledge and greater skills, then you create the potential for people to become a disability champion? And having champions can be very important in terms of changing attitudes and sharing their knowledge in workplaces. So am I right in understanding that when you're talking about a disability champion, you're not just confining it to the health environment, but across the board in all areas of life, is that right?
We have people with lived experience of intellectual disability all through our services. What often happens is that expertise is not celebrated or utilised or shared. If we had a way to include their learnings into committees and ideas around how to address issues for people with disability, you would get, for example, I think, more low literacy resources being developed. You would get people who could actually review things, as well as those with lived experience of actual intellectual disability. But there are some people whose experiences won't be represented by people with intellectual disability who can speak up for themselves. And so you still need this dual representation. So, you know, instead of them feeling like they need to hide their experience, we should be utilising it in a way that it's celebrated and opening up accessibility within services. And I think it could be a very powerful change agent, and instead of being seen as someone who has to maybe have a day off here and there because of the needs of their person, it actually becomes a value that they're bringing back.
One of the other changes that you suggest is the use of equipment and technology, and we've touched on this. This is the hospital passport and using pictures and developing appropriate resources for low literacy. So we've touched on those things. And also using the CHAP assessment tool or something akin to that, which ensures that you've got reliable health information and also appropriate annual checking. Is that right?
The other thing we need is a USB with a video of what the person looks like as their normal baseline. What clinicians don't have is a sense of what that person looks like, for example, before they have their seizure or before they have a critical incident. So their assessment is challenging because they don't know what they're meant to get back to. And with all of our technology, we have cameras on all of our phones that can videotape. And if that information is then popped on a USB together with other pertinent information, that would set... I have this mantra, you set people up for success. If we have a system that lets us set people up for success, we will stop discriminating because we will be looking after the needs of the clinician who needs to know what someone looks like before they had the seizure. We will have people wanting to develop resources because they want to communicate with them. And during Sarah's hospitalisation, I asked the doctors if that would be useful. And I said, could you play it? Because I wanted to know if their computer systems would enable them to play it, and it would. And it's something so simple, and it would, you know, be very easy to do, but it would actually assist a lot of people in doing that.
So the next area is legislative reform, and you've touched on this already with the Royal Commissioners talking about the Equality Act in the UK, but what you would like to see is stronger laws so that if there was to be an implementation, for example, of a disability action plan or inclusion plan, that there would be legal targets that would have to be met by health providers. Is that right?
Well, I think that the end game is to have something that speeds up the necessity of organisations and businesses to need to provide accessible services. Funnily enough, when you address the needs of people with intellectual disability with their communication, you're also addressing the needs of people with English as a second language, people who've been through trauma, people who have Alzheimer's, who have got memory issues, people who are stressed. We have also a support worker population who often come from outside of Australia, or many will have learning disabilities not picked up. And so it's easier for them to read information like that as well. And I'm not saying that they're stupid or not able to. In fact, it's easier for health professionals as well to read easy language so you don't have to decode so quickly.
Data collection is something that you mentioned in your statement about the importance of accurate data collection and data collection that allows people to undertake research, but also to ensure that you've got some accurate material for the development of policy. So you've talked about that. You've also talked about some of the issues which we've touched on with the NDIS and your very strong views about community visitors. But I'm interested just in terms of your very recent experience, and this is towards the end of your statement at paragraph 149 and 150, is that even at the end of somebody's life, if they've been an NDIS participant, is what is available for families in terms of bereavement and grief counselling. And do you want to say something about that? And then I'm going to ask you just to read the final three paragraphs of your statement.
I think the NDIS is still young and it hasn't got a mature approach yet to quality and safety for people with intellectual disability. And that's obvious when you look at this gap around when someone dies. I don't see how you can set a process up where you have one bit of information that isn't corroborated in a system like that and also take the CVS out at the same time. That and also the inconsistent information, that sort of thing. And what doesn't surprise me, sadly, is that the needs of the people who have been that person's main provider and carer is forgotten yet again. And it's like they get a message saying number X394 has died, and that's it. They cease to exist as far as the NDIS is concerned. And we've put in a lot. We have suffered enormously, and we also have then just left our previous tribe. We're no longer the parents of a disabled child.
But you are.
But we're not the other either. And so there's no thought about how you transition back to not having that child. And it just, you've got all this equipment that we had just bought. I think it was an $8,000 bed through NDIS. It's a month old. Why are they not asking me about what's going to happen to that? I don't know, maybe it'll help pay for her funeral, I'm not sure, but they have not asked about any of it. They haven't sent us a condolence letter. They haven't said thank you for what you've done in being her nominee. Frankly, it's bad manners, I think. But as far as the quality and safety system, you've got to be joking. There's no accountability around the equipment, there's no accountability around the fact that Sarah had a valued life. And maybe I could have then told them about the number of NDIS smiles I had last year, because they might have actually heard some really good stuff that they could start to promote as well in doing that. But they don't get the good bits, they don't care. No, it's not even that they don't care, they haven't even thought of it. That's the thing that boggles my mind, is that these people are paid a lot of money. And I wish I could just get in there. I tried as a diabetes nurse specialist to get to someone in the commission and the framework to talk to. I have never seen an organisation hidden behind so much secrecy. It is a planned approach that there is nobody's name. You never get a person to call back. You don't have a phone number. There is no email to respond to somebody. Even when I was asking about the emergency review, it is a strategy in order to hide behind a wall of secrecy. How do we let that happen in a place like Australia where we've spent government money putting all this money in place and we don't have a person to call? We don't have a person with accountability. It lacks accountability at every step, every step. And that's how it's been set up. And I have to say, it must have been set up like that on purpose. That is criminal. That is, I think, discriminatory, because it's people with an intellectual disability, the very people who cannot communicate their message. They've made it even harder for them to tell their story. Sure, on the little pamphlets that come out, it's all about their story, but only if the Commission wants to tell you. So how can we have a government instrumentality that is providing a service with taxpayer money with no accountability? I don't know. And I'm relieved on one level not to have to deal with that anymore.
That's why I wanted to, do you say that in your statement? And I wondered if you wanted to read just those final 3 paragraphs or even just that final paragraph.
It's from the 149?
From 152, just under the heading conclusion.
I don't even know if I've got that page.
Right, would you like me to read it? Okay. You say this. In conclusion, it has not been easy preparing this witness statement in the wake of Sarah's recent death. We loved our Sarah Kate dearly, and we tried to give her a life that had the same opportunities as our other 2 daughters have as Australian citizens. However, I am relieved as well that I no longer need to worry about what happens to Sarah if I die. Her sisters are no longer left with the onerous responsibility of stepping in as her protector if my husband and I died. We live with these fears because of the number of times the systems, like healthcare systems, have failed our intellectually disabled family members. It is time to relieve us of that fear by delivering recommendations that ensure equality of access to health for all. And in so doing, sharing Sarah's health experiences will not have been in vain. Ms. Lehman, thank you for coming to give your evidence.
Thank you.
Again, I express on behalf of the Royal Commission our deep condolences for your very recent loss, and I thank you for the courage to come and speak to us at the Royal Commission at what is a very difficult time.
Thank you for the opportunity.
I thank you too on behalf of my colleagues and express our profound sympathy
Thank you.
for your loss. I know it's only 2 months since your daughter passed away, and I know how difficult it must have been for you to prepare this statement, and we thank you for doing that and for sharing your experiences. It's a wonderful way to honour Sarah's memory that you're prepared to do this and to keep fighting.
She and others deserve it.
They do, and thank you so much for doing it.
Thank you.
Commissioners, we might take a short adjournment.
The Royal Commission is adjourned.
The Royal Commission is resumed.
Yes, Ms Eastman.
Commissioners, we have two witnesses who'll give evidence together. So Karen Barnett and Tracy Nash, and I'll just ask them to come up.
Please do sit down, and if you wouldn't mind taking over the oath or affirmation, as the case may be. Thank you.
Karen, you're taking the affirmation.
I'm Karen.
Sorry.
You're all right.
Do you solemnly and sincerely declare and affirm that the evidence which you shall give shall be the truth, the whole truth, and nothing but the truth?
Yes.
Tracy. Do you swear by Almighty God that the evidence which you shall give shall be the truth, the whole truth, and nothing but the truth?
Yes.
Thank you very much. Yes, Ms Eastman.
All right. Can I call you Karen and Tracy, or would you like me to be a little bit formal, Ms Nash and Ms Barnett? What's your preference?
Tracy's fine.
Right.
And Karen's fine.
All right, thank you. So let me start with each of you in turn, but we're going to be dealing with the evidence together. So Karen, you are Karen Barnett.
Yep.
And you're a teacher.
Yes.
And you prepared a statement for the Royal Commission.
Yes.
And that's dated the 12th of February this year.
Yes.
Commissioners, a copy of the statement can be found in Part A, but behind tab 37. And I'm going to deal with issues of exhibits and the tendering perhaps at the end of the evidence, if that's convenient.
Yes, thank you. We have
and then now, you are Tracy Nash.
Yes.
And you are a carer.
Yes.
And you've provided a statement to the Royal Commission dated the 10th of February 2020.
I have.
And Commissioners, you'll find a copy of that statement behind tab 38. So can I just acknowledge to you both, I'm sorry about the delay in giving your evidence today. I think you were ready to go first up, and we're very pleased that we're able to take your evidence this afternoon. So, Commissioners, during the course of the morning, there's some additional documents which are relevant to this part of the evidence that have been very recently included in the tender bundle, and they are marked 32 capital A through to 38 capital H. And if I need to come to some of those documents and identify them in the course of the evidence, I'll do so. So for both of you, I think it's fair to say that when you prepared these statements for the Royal Commission, you did it based on your memory. And at the time, you didn't have copies of clinical records or copies of letters and copies of documents. Is that right?
Yeah, very minimal. Part of the grieving process, because it is nearly 5 years since Grant died, since Butch died. I call him Butch. Childhood nickname. I'd sort of decided that it was time to let some stuff go, and so I unfortunately had deleted emails and other correspondence that I had received from.
And so I think you acknowledge, don't you, both in your respective statements that you've done your very best to remember particular dates, but if you've missed out a date or a date range that wasn't intended.
That's correct.
But you've done your best to remember dates and times.
Yes.
And I think you've been shown some documents during the course of the morning.
Yeah.
And those include some of the hospital records, is that right?
That's correct. Yeah.
And that might have identified some dates which might be a little bit different to your statement.
Yes. Yep.
And you've also been shown some documents, haven't you, that might give a slightly different perspective on some of the issues that you want to raise in your statement, because you've seen what the hospital has to say about those things.
Yes.
Right, so you're both nodding. But the evidence that you set out in your statements, when you both made your statements, was really that you sat back, and I think, Karen, you say you learnt that the Royal Commission was starting, and you thought, even though I've tried to put behind me the death of my brother, that just hearing about the Royal Commission made you think, I think I need to come to the Royal Commission and tell the Royal Commission what happened to my brother. And that was part of the motivation in preparing the statement that you have.
Yes, that's right.
And Tracy, as a carer and a supporter of the family, that you also wanted to bring your perspective to the events a number of years ago as a carer. Is that right?
Yes.
So, Commissioners, I think it's important to understand the context of the evidence. And as we have said on a number of occasions during the course of this hearing, This is not a hearing where the Royal Commission is stepping into the shoes of the Queensland Coroner. It is not a hearing where the Royal Commission is stepping into the shoes of the Queensland Health Department to undertake clinical reviews. It is not the role of this Royal Commission to make any particular findings as to whether anybody was negligent or that anybody did any wrongdoing in relation to relevant Queensland policies and the like. The purpose of your evidence is that you want to share your brother's story and you want to share the perspective that you have of his experience towards the latter part of his life. Is that right?
That's right.
Okay, so now I've done all of that introductory work. Let's get into hearing about your brother. So, Karen, you had a brother. His name was Grant.
Yep. You want to know about him?
I want to know about him.
You want to know about him? He was a smart-ass bastard. He was a lovable rogue with quick intelligence that could take you down. Like, people often stared at him and thought he lacked intelligence, but he was very quick-witted. I'll give you an example. After Mum died...
Hey.
Sorry?
I'm going to slow you down.
All right, okay. So I'll give you an example of...
have got to follow.
He's supposed to be intellectually disabled, but he had a quick wit. And after Mum passed away, my sister moved into the house to help Dad out because Dad was grieving quite severely for the loss of his partner. And he was also trying to lose a bit of weight, very big family and stuff like that. And Dad said to my sister at dinner time, "I've lost 5 kilos." And Butch whispered under his breath, "Still a whale." But Dad didn't hear it because he didn't have his hearing aids in. So, you know, it was quick. He wasn't stupid. He loved travelling. Lo and behold, if he didn't have coffee, tobacco and scratchies in the morning, because you'd hear about it. He loved machinery. He collected cans and crushed them to make money. He travelled extensively with my parents, and he also, just a couple of weeks before he had the accident that ended up breaking his leg and then set him on the process of his death, he actually had just been to my place just out of Newcastle. He'd flown, he used to fly from Longreach by himself, and he needed assistance to seat shift to get it transfer from one seat to another. I met him in Brisbane, and then he'd come out to Alice Springs for a month with me and stuff like that, so this is a man that was very active, very clever, very out and about. He had lots of friends that were... He made friends himself. When my parents moved to an outback town in Queensland, in Barcaldine, he somehow struck up friendship with the people that owned the Smash repairs there, and they loved him coming and visiting. He made friends with lots of truckies driving through the town. He was just interested. He asked questions all the time. I remember driving past the catchment up near Newcastle, and there's a big lake there, and he said, "Where's the boats? There's not a boat on there and there's not a bird on there." And he had noticed that. Now that's not intellectual disability to me. That's how I grew up with him, and yeah.
But he did have an intellectual disability. Yes. And why? To Grant's health. But Tracy, can you just tell the Royal Commission what were your responsibilities as a carer? And we'll preface it just this way, that you started in June 2014, but a few days after you started, Grant had a fall, which resulted in a hospital admission. So perhaps when you started the job, you had an expectation of your responsibilities, but they changed pretty quickly in the first week.
I did.
So can you tell the Royal Commission what were your responsibilities and what did you do as a carer?
I was responsible for Grant's health and wellbeing, his personal care, some cooking and cleaning his room and making his bed, and taking him out on social outings, and also to doctor's appointments and anything else that he really wanted to do.
Okay.
Basically, that was my
And you developed a fairly close relationship with Grant as his carer.
The whole family.
And the whole
Yeah.
family.
Yes.
And so you've heard the sister talk about Grant.
Yeah.
But what's your recollections of Grant and the person that he was?
Well, as you said, my first day, on the Monday, I showered him, and that was fine. By the third day, I showered him, and he was due to go out of the service provider, and I went off on my merry way thinking I've got a bit of respite, and I was given a phone call that Grant had fallen out of his chair while he was out and had broken his leg. And what else did I need to say? I can't remember. And I thought my job was over when Norm rang me and said that I've got some bad news for you. And I'm thinking, they don't want me, Grant doesn't like me, I'm probably sacked. But it wasn't that. But I went straight up to the hospital to be with Grant to make sure that he was okay, and Norm said, yeah, come up, see what happens. Yeah.
And it took you a while to learn the best way of communicating with Grant, is
Yes.
that right?
I remember.
So just pausing, I think obviously, as a sister, you'd worked out your forms of communication.
We
And this
grew up
was-
like twins. I was younger than him, so we often didn't need to communicate at all. And I was actually his translator at the dinner table for the whole family for a long time. And I did his personal care from a very young age because my parents were busy on the farm, and my sister had no patience much. She was good, but she was better with doing the games and stuff. I was better with the personal care and stuff.
So in terms of communication, when you came to work with Grant in June 2014, it took you a while to learn the right communication, is that right?
He was very hard to understand at times when you first met Grant. You didn't understand the words straight away. And he wasn't born with the gift of the gab like this one. Sorry. He talked in short sentences, but he got his message across. Like, if he didn't like something, don't like. Or if it was just a yes or no answer, yes, Tracy, yes, Norm, whatever, or no, depending on what the answer was. But he knew how to get it across so you could understand him. He would never do like sentences, long sentences, and a little bit garbled sometimes, like when he was saying his name. He never said, when you asked him his name, it wasn't Grant Barnett, it was Aunt Barnett.
Okay.
When his birth date was 4th of July, he would say 4th of July.
Okay.
But he never ever said the year, that sort of thing. So you had to sort of get to know 4th of July is 4th of July,
And once you did get to know him and you developed a good communication with him, how did you, Tracy, get to understand whether he experienced pain or he had particular health needs?
Well, most of the time I could see it on his face, and I'd say, do you hurt, Grant? Have you got a pain? He'd say yes, and I'd say where? And he would either say tummy or head or something like that. Do you want something for it? Yes. Then I would talk to Norm about it, and we discuss what the treatment was.
Okay. So I want to now turn to the occasions where Grant had to have an admission to a hospital, and just your recollections about what happened during those various admissions. So the first that you were involved with, Tracy, occurred in June 2014 or thereabouts, and Grant had suffered a fall while out with a day program service provider, and the diagnosis was a broken femur. Is that right?
That's correct.
And this is Norm telling you the bad news, but you went up to the hospital, and Grant was in the hospital for a number of weeks. Is that right?
I think so, yeah.
And,
I remember, yeah.
And to the best of your memory, you spent most days at the hospital with him?
Every time he was in hospital, I was there every day, all day.
And your recollection of that time in hospital was that the doctors and nurses would never speak to you directly. They mostly spoke to Norm, Grant's dad.
If I was the only one there, then it would be me. But if Norm was there, being that he was the guardian, he was the one they spoke to.
And
I was there.
You recall that there were some times where the hospital staff wouldn't even talk to Grant if he needed an injection in his stomach.
That's correct, yes.
And when the hospital staff did speak to Grant, do you recall how they engaged with him?
When they did, it depended if they knew him or not and if they got to know Grant. Example is if it was a wardie and they got to know Grant from previous interactions with him, they'd learnt that he liked aeroplanes, and he would say Virgin coming.
Mm-hmm.
And that meant that a Virgin Blue plane was coming in, and they got to know him by that, and they go, oh, I know you, you're the aeroplane man. Grant always knew when one of the planes was coming in and what plane it was.
So that there was different experiences in the hospital. It's not everyone didn't speak to him, but some did, some didn't.
Yeah, it depended if they knew him or not. And if they... I remember of a morning when they come in first shift, I was always there before breakfast, and the nurses that come in when they did the shift change, it was never, hello, I'm your nurse for the day, and my name is, and I'll be looking after you. It was nothing like that.
Just coming in.
Just coming in, and you would see them giving a handover, standing at the end of the bed, not even acknowledging Grant, saying good morning or anything like that. They would just give their handover, which is fine, but after they did that, they didn't come and introduce themselves like you do when you see them. You're sitting there in the ward, somebody else across the way, good morning, Mrs. or Mr. So-and-so, I'm nurse, I'll be looking after you today. They didn't do that with Grant, and I was noticing the difference there.
And prior to Grant's discharge, you noticed that he started to develop a cough, and Norm knew from his years of experience looking after Grant that there was a risk that if Grant's cough was left untreated that he might develop pneumonia, and the concern was that that could come on quite quickly.
That's correct.
So you remember Norm talking to you about that, Tracy?
Yes, I'm remembering that I was still getting used to him and getting to know him, and I learnt a lot through Norm and what he told me about what would happen. And he used to say to me, if ever you see that, Tracy, that he starts a cough, you must let me know because he's susceptible to pneumonia or it'll go to his chest.
And do you remember Norm noticed the symptoms and he tried to raise the concerns that he had with the doctor, is that right?
That's
Before
correct.
Grant was discharged?
Yes.
And you recall a discussion, so this is something you heard with Norm and the doctor, about the doctor giving antibiotics, is that right?
This is correct, yes.
Okay. And in terms of what you remember about whether he was or wasn't given antibiotics, have you had a chance to look at some documents to help remember whether he was given the antibiotics?
I believe he was at some stage, but I can't remember on what occasion. Grant was more, that may have been the first time, but there were other occasions when Grant, over the time that I was with him, that developed. So I can't remember exactly what time, at which occasion he was given antibiotics.
All right. So in terms of what occurred after Grant left hospital with having spent time with the broken leg, there was a series of physiotherapy appointments, is that right? Did
That's
he have
correct.
to attend the physiotherapist?
Yes.
And your recollection is that there was a problem with the physiotherapy, is that right, Tracy?
Yes, I believe in the way that she spoke to Grant in a very harsh tone. You've got to know Grant, that if you speak to him in a rough way that he doesn't like, he will not be cooperative, he won't listen, and he won't do what's asked of him.
Right.
But he's got to like you to do anything.
And did you have to do anything yourself to assist him in terms of the rehabilitation?
I was trying to cajole him into doing what the physiotherapist wanted by enticing him and saying, look, we'll go and get a scratchy. When you finish, just do what the physio wants you to do. We'll go and get a scratchy, we'll go down to the Bagara, we'll go and, go and get a Coke and whatever that he wanted. But the way that I perceived the way that she was acting and talking to him was exasperated, which annoyed Grant, and he was not going to do that. I tried my best, but if he got it in his head that he didn't like them, he wasn't going to do it. But there was no other way that she tried to do it, and she didn't try a different method, or didn't ask if he was in pain, is that why you couldn't do it, or anything like that. It was just, you've got to do it.
And you say you took Grant home after one of the physiotherapy sessions and you said to Norm, I don't think we'll have any more of these physio appointments. She doesn't seem to like Grant very much.
Yes, before I left that appointment, and there was it was obvious he wasn't going to do anything, I asked the physiotherapist, do we have to make another appointment for any more for any more physio? And she goes, what's the use? He's not going to do as we ask. We can't work with him if he's not going to do what we ask.
Okay.
So that's when I said to Norm, I don't think we're going to get any more appointments.
All right. And Karen, you were not actively involved in this?
No, but I know from personal experience that if you made a game out of stuff, like I have a long history of working with people with disabilities. I was a residential care worker myself in the 80s. I've maintained friendships with people that I 25-year friendships with people I used to look after. I'm now a teacher that works with children with disabilities all the time. So I sort of get it. You know, if you make it fun, and Butch would do stuff, just to get him to have a bath when he was young, even later, was you had to make it into like a song or a game. And I just couldn't believe it when Tracy told me about that. And I went, hang on a minute, you know, like anyone knows that people with disabilities might need to actually have an alternate way of, they're not going to do as they're told, especially with certain conditions and things like that. So I was a little bit disappointed that such a serious break, and you know, you only have to read the data to know that people who have breaks, have breaks like that are wheelchair bound, if they're likely to be dead within 12 months. He was, you know, if they don't get the proper care. And that's the reality. He was dead within less than 12 months of that break.
Well, before we get to his passing, there were a few other occasions where he had to be admitted to hospital. So can I come back a little bit?
Yep.
And so, Tracy, in August 2014, Grant suffered a stroke and he was again admitted to the hospital.
That's correct.
And you recall this occasion, don't you, because he'd been sitting in a chair at home and you observed that he had something that looked to you like a seizure.
That's correct, yes.
And you were home at the time.
Yes.
You called an ambulance and then you travelled with the ambulance and Grant to the hospital.
That's right.
So after you arrived at the hospital, the medical staff conducted some tests and you were told that he had a minor stroke, is that right?
Yeah, yes, a TIA, yes.
And again, he remained in hospital for a period of time, is that right?
Yes, that's correct.
And again, you spent every day at the hospital with him?
That's right, yes.
And on this admission, your memory is that there were many instances where the staff didn't listen to Norm or when Norm wanted to raise issues about Grant's care, or they ignored him, is that right?
That's right, yes.
And you felt that the hospital staff didn't attempt to communicate with Grant in a manner that was appropriate for Grant, is that right?
That's correct. It happened more than once every day. You know, a nurse who didn't know him or some medical staff that didn't know him did not address him at all, not, hello, how are you, Grant, or anything like that.
Okay.
It was, yeah.
Some nurses, you say, were good and they realised that there was a way to communicate with him, but others you found...
Once you pointed out that Grant could talk and could answer yes and no questions like, are you in pain, Grant? He could say yes or no. And they realised that, so the next time they came to visit, they would ask him. But if they didn't know, I was the one they asked. Mm-hmm. You know, do you think Grant's got any pain? Or ask him, you know, that sort of thing. And that's how they learn.
So you haven't addressed this in your statement, but the Royal Commission has heard evidence last week about a person with intellectual disability having a stroke, and that occurred in a New South Wales hospital, and there was something called a stroke protocol, so which dealt with rehabilitation following a stroke. You haven't made any mention of that. Do you have any recollection at all of a stroke protocol?
That's why I haven't mentioned it. I don't have any recall of any of that. Okay. That's why I haven't mentioned it.
Right. So when Grant came home after suffering the stroke in August 2014, what was the difference for him in terms of his care and his...
What my needs... because of the broken leg, he could no longer transfer.
Mm-hmm, that's right.
And we were hoping to get him to transfer from the bed. And we managed that with Norm buying a slide a bed slide, so he could go from the bed to the chair, but he was never able, because the bed was a little bit higher than the chair, he could never go the other way.
Right.
So he was hoisted, and yes, he was a bit slower to respond to things, and his speech wasn't as clear as it was before that, but, you know.
But you wanted to try to get back to whatever the normal was.
That's right,
before
yes.
he was in hospital.
That's
is that
right, yes,
Okay.
that's right.
And Karen, did you see or speak to Grant during this period of time?
Yeah, we rushed up 15-hour drive from Maitland to be there overnight and walked in. You're here. Oh, you're here too, beautiful. All right, okay, so he responded really well. We had brought our dogs with us, and I remember being we're taking him out for a walk to get him out because he was finally allowed out of his bed because he'd progressed quite well once my sister and I had arrived. He seemed to love us for some reason and come back from the dead many times. So we were out in the courtyard with the dogs and stuff, and coming back in, ran into the head doctor, and she just stopped in her tracks and looked at me and looked at him and went, pretty much, wow, what a change, because she hadn't seen him for a couple of days or something like that. Wow, what a change in that. And Butch had picked flowers and he was trying to hand them to her, and she just completely ignored him and stuff. And I actually had to say to her, he's trying to give you flowers and say thank you. He's trying to give you flowers. And then she sort of looked down and went, oh, okay. And then she acknowledged that Grant was there, like Butch was there, and I just found that really disappointing. I really did. I thought, okay, he's your patient, he's trying to talk to you, how about listening, you know? Like, yes, you mightn't be able to understand him, but, you know, he's actually a nice bloke, you know, and it's not just a piece of meat on a bed. So, yeah, it was a bit...
But you weren't there when he went back home after being discharged, were you, Karen?
I think I think
you were there.
I was there for a few days, so I think I might have left when he went home. Yeah, I think once he was discharged from hospital, we went home and stuff like that. So,
right. So things travel along until October 2014. And this was a fourth admission to the hospital, and in October 2014 Grant had suffered another stroke, but this was a stroke that was far more severe, and it also ended up with him developing, as you both say in your statements, life-threatening pneumonia. Is that right?
That's correct.
And Tracy, again, you attended hospital every day while Grant was in hospital, and you spent most of the day with him.
That's right.
And you say that you remember both Karen and Naomi travelling to have a bedside vigil.
Right.
So it was pretty dire, wasn't it?
It was.
I was staying overnight for the first 3 nights. My sister and Naomi and I were for the first pretty much 4 or 5 days, we stayed overnight because we thought he was going to die, and we wanted to make sure he had a family member with him, because... You know, I wouldn't want to die alone in a hospital, if you get my drift, you know. Who wants to die alone in a hospital and not have the people that love you around? You know, and they were sort of saying that we couldn't, but I said, well, try removing me. I'm staying. This man needs me. He's my brother. And would you do that to your family, you know? Like, I'm staying. I know it wasn't policy for them to have family overnight, and probably there's been problems, but... I slept in a chair or sat in a chair and made sure he was okay. Swapped with Naomi at some stage one time.
How was Norm during this time?
Devastated. Found it very difficult to come to the hospital in some ways, you know, because he was like, oh my God, what's happening, you know? Dad wasn't in the best health either. The reason why we had to employ Tracy was because he'd put off his own medical conditions because he'd looked after Grant and my mother, and he'd put off his own medical conditions, so he had a twisted bowel and couldn't do full-time care of Grant anymore, you know. So we employed Tracy, which was just godsend, because Naomi and I actually spent 4.5 months in Bundaberg. Like, I live in New South Wales. Naomi was living 8-9 hours drive away. That year we spent 4.5 months each
Going back and forth.
And
going back and forth, being there to either give respite to Tracy or being there initially for periods of time to make sure Grant got the appropriate care, because even though Mum and Dad had looked after him for so long and was so astute in when he turned 18, when he got the disability pension, that they put money away, I mean, I'm going to say that there was no, what I got told by disabilities in Bundaberg is we didn't realise the extent of his disabilities because he'd been looked after by your mum and dad for so long. All right, so I said, so we're going on a waiting list just when mum and dad, well, dad would need you. There's no one to help us, you know, like dad can't care for him anymore. We can't leave our jobs and stuff. You know, like this is a terrible system. How does this work? We've saved, and I'll put it there too. During that time, those hoists and wheelchairs and that were bought by my father, not provided by the government. The house was modified and the bathrooms were modified at my parents' expense, so they could accommodate my brother. When he had that final stroke, my father, who wasn't well himself, travelled to Darwin to get a wheelchair bus and drove it back to Bundaberg so my brother could still have outings even though he could only just move his head and one arm. These are people that had thought about what was going to happen as Grant got older. These were people that basically saved millions of dollars to the governments in Tasmania and Queensland and wherever else over the years because they refused to have residential care, they refused to overload the health system, and they knew what their responsibility was, and they did get some help. And it was actually me who said, because when Dad had to have a hip replacement, I said, Mum, we need to get somebody in to shower Grant, you know, because Dad had been showering him, and then Dad, and that was the best thing because it meant Dad could go off in his mornings again and do gardening and stuff like that. It gave Dad a little bit of freedom in the day. I just don't get it. I don't get why that system means that the people, when they need it most, when they're getting older, they have to go on a waiting list, and they're killing themselves to care for their disabled children.
Karen, can I bring you back?
Yes, sorry.
To the hospital admission. So this is Grant had suffered a very significant stroke.
Yep.
And he was in the hospital until December 2014. And there's a few issues that you wanted to raise about your both respective recollections about the time that he was in hospital. And both of you say in your respective statements, that when he was in the hospital, he didn't receive a proper shower for 21 days. And you both have a recollection about that. But you do say that you did observe that if he didn't have a shower, that he might be rubbed down with body wipes.
Yes.
While he was in the bed. Now, I think someone has drawn to your attention the hospital records in terms of showering and hygiene issues generally. Is that right?
Yes.
And so is it the case that both of you recall that he went for a period of 21 days without a shower, and that's your recollection?
That's correct.
It's definite. It's like a man the size of my brother. Now I'm short. He was nearly 6 foot. He was obese. He was difficult. Even when he was moving, he was difficult to shower or wash or give a sponge bath to because he had lots of creases and places where it was difficult to get to. And it was like that he was incontinent. You can't go 3 weeks or a number of weeks without a shower. You smell. You can't get, and on a bed, you can't get into those places where you need to get into, and just wiping somebody down, you know, I don't know, there should be designated teams that that are called in to hospitals when people like my brother are in there that actually go around showering them, because you can't put that on the nurses. I mean, I know that the nurses there, they were doing the best they could. They had some horrible infection in the next ward that they were trying to keep out of every other ward, and they had to gown up all the time and things like that. So putting that onto the nurses and I think most of the nurses were trying to do the right thing, you know. They just didn't have the time. They were underloaded. So having a designated team that actually comes in and feeds people and showers people would be a really good idea. And what did you
Yeah, my understanding was whenever I asked on numerous occasions, could Grant have a shower today, it would be either, it depends on what the wardies are doing, the wardies are busy. Their policy was 2 wardies and a nurse, just bed sponge him, and basically the same with a hoist and, you know, full sling hoist into the shower. But I kept trying to tell them that if you could get him onto the chair, I could do it, because I do it all anyway, hoisting onto the shower chair and into the shower by myself, occasionally with assistance from Norm, and eventually when he did come home with another person helping.
But you've seen, haven't you, now that the hospital says that Grant did receive some full showers, some sponge baths, and that his hygiene was cared for in relation to his incontinence. You've been shown some records or told about that today. Is that right?
So why did he have bits of gunk stuck between his fingers and in his groin that stunk? When Tracy and Dad finally were allowed to take him home to shower him, why were there stinky, grimy, grotty bits in the creases and between his fingers that obviously weren't properly cleaned?
One of the issues for you, Karen, was that you wanted to see whether he might be able to come home during the period of the time that he was in hospital. And I think this might be referred to as gate leave. And
sounds like prison, doesn't it?
But your recollection is that you and Norm thought that the best prospect for his recovery was to be in a familiar environment outside the hospital, and you advocated that he be able to come home during the day, and your recollection is that there was resistance to that it would be against the medical advice to do that.
It wasn't the done thing at the time to take a patient home to shower
right,
and to have some sort of respite from the hospital.
Yeah, so a respite from the hospital.
Yeah, for Grant to flourish. Grant didn't like hospitals, wasn't
the done thing, but you advocated,
yes,
and your strong advocacy resulted in Grant having what is described as gate leave. So you agree, don't you, that it wasn't simply that you asked and the answer was no. It might have been challenging, but eventually you got there.
With persistence from Norm, yes, it was agreed to.
But during that course of his period in hospital, from October to December, he was able to come home.
That's correct.
During the day,
yes,
and then return to the hospital at night for care. Is that right?
It appeared like they were trying to delay that.
But yeah, there were times on some days, instead of it being like Norm wanted every day, they may have wanted it not to be every day. So some days there were issues put in front of us, barriers.
Or appeared to be anyway.
That's your perception, and the hospital might say, well, you know, it is a bit unusual and it was against the medical advice and we suggested it wasn't a good idea, but eventually we agreed with the family. You accept that?
Correct.
And he did. He improved drastically once he was allowed home. The other thing about that is no one was asking him. None of the medical staff were asking him. He was going, I want to go home, Dad. I want to go home, Karen. I want to go home, Tracy. I want to go home. I don't know what was wrong with understanding that very simple statement by a human being, but according to, you know, like, that was not allowed. And I don't know, as a child, he was sent home from hospitals to recover because they knew, the medical staff in Tasmania knew that he would recover better in a familiar environment with his family. And I just don't understand why that was hard, a more difficult issue in Queensland.
It was frustrating for all of you, wasn't it?
And the inconsistencies too, when one day they'd say, we don't have a sling, or we can't get the sling just yet. Norm would have a sling now and bring it up. And one day we were allowed to use it. Then the next time we wanted to take him out, someone say, oh, that sling's against hospital policy. It was like, well, it was all right yesterday, but it's not right today, those sort of things.
So, Tracy, one of the other matters that you deal with in your statement was Grant's diet during the period that he was in hospital. So he was fitted with a feeding tube, is that right?
That's correct, yes.
And that was because he was having difficulty swallowing due to the stroke?
Yes.
And as far as you understood, in terms of what his nutrition was, that was a pre-mixed food out of a carton. That's your memory?
Yeah. Initially, it was a nasogastric tube, and we were told that because when we were taking him home, Grant was attempting to feed himself.
When he was at home?
When we took him home from the hospital, he was attempting to eat something, but it got in his way.
Right.
And then they said, well, if he was to go home, he would be fitted with a gastronomy tube through the stomach. And
that's what happened?
We understood that's what happened, yes.
So this process of the gate leave, when he was going home, having a shower at home, but also you wanted to have some variety in his diet. And I think your concern and Norm's concern was that the nutrition and the particular pre-mixed food used for feeding him through the PEG feeding was high in sugar.
That's correct.
And so you were worried about that, what effect that might be having on his blood sugar
Yes,
levels?
both Norm and I were, because whenever his blood sugars went up really high, he was injected with a drug to bring them down.
Okay, so you're worried about that?
Yeah, very worried.
And you and Norm thought, well, look, maybe we might be able to do something different in terms of his overall nutrition.
That's correct.
And am I right in understanding that Norm wanted to push for a change in Grant's diet, and you made some inquiries with his GP about what might be, or is there something that happened before
Before
that?
he left hospital, Norm wanted to know why we couldn't put real food, as he put it, down the tube. It's not the done thing. It's not very common.
Do you remember the hospital saying it's not the done thing?
Yeah,
and if you
can't
do
be
this,
done.
it can't be done, but if you do this, there's a real risk that this might cause some harm to him, or that there might be a block in the feeding tube, and that this could be dangerous.
The tubes weren't
something
made,
like that.
The tubes weren't made for it and all that
Tubes
sort of
weren't made for
But
it.
Norm had an argument for that.
Right, what was
Norm's argument was that he had a sister who had throat cancer, and for nearly 15 years or so, she fed herself real food through a tube.
In the
and he couldn't see why it couldn't be done for Grant. Even though we knew and we'd researched it, and from Norm's personal experience, that as long as the food was blended up with we had a NutriBullet to the consistency of pouring so we could gravity feed it through, and Norm did the cooking, made the soups and the stews, and I blended it up to what was consistent to that. Would flush the tube beforehand, gravity feed it through, flush the tube afterwards to make sure everything was great, and then do the same thing the next time. And it was, well, for that time while we were at home, till the next incident, I believe it was very successful. Not only did, we first of all, after he came out of hospital, with all this carton food, we went to the GP and asked, can we try it? The doctors in the hospital don't.
That was after he'd left.
This after he'd left the hospital.
Not before.
Not before.
Just wanted to clarify
Yes.
that. Yep.
Yes. And the GP said he couldn't see why not. And Norm stated to the GP that his aim was for Grant to lose weight, feeding him real food, and to get his blood sugar levels under control.
Okay.
And if not, get him off the medication altogether, because he was told while Grant was in hospital that he would be insulin dependent for the rest of his life.
Right.
Norm would not take that as a...
Norm was pretty determined, wasn't he?
He was a very determined man, yes.
Right. Okay, so by December, Grant returns home.
That's correct.
And then I just want to go to the next issue and the next admission. So Grant had the feeding tube, but that did need to be changed from time to time, is that right?
Yes, we were led to believe that after 3 months after it was put in, it was to be removed by the doctor that put it in, and then have another one put in, that later on that the gastronomy nurse, stoma nurse as they call them I think now, could then teach me how to, if there was any issues, to change it, or if it came out, if I wasn't comfortable with it, I could ring her and she would come and have it done at home with this new one.
All right. So you took him up to the hospital for what you believe to be a routine procedure?
That's correct.
And at the end of March 2015, what happened on that day, from your recollection, was far from being a routine procedure.
That's correct, yes.
Can I summarise the evidence this way?
Yes.
Your recollection is that when Grant came to the hospital, that a doctor came into the room and in quite a sort of forceful way pulled the feeding tube out, is that right?
That's correct.
And you observe Grant experiencing some pain?
That's correct.
And then that resulted in Grant, so you say having the tube removed in that fashion and the attempts to replace the tube caused either Grant's bowel to be perforated, but you later have learnt that the perforation was in relation to his stomach, is that right?
That's correct. After all that happened, somebody came in, a medical student I presume, and talked to Norm and I saying that Grant needed an operation for a perforated bowel.
That's what you remember being told?
That's what I remember, yes. And Norm didn't quite hear, after explaining that he needed to go under anaesthetic, what the risks were, and that it was a perforated bowel, he needed to sign something. Norm didn't hear it, so I had to then tell Norm what he was saying and clarifying that Grant had a perforated bowel and he needed an operation to repair it. And Norm signed the form to give the permission to operate.
So Grant had to have an operation?
That's correct.
And when
it wasn't the simple procedure that I'd led Grant to believe.
So you had assumed, from what you have been told, that the operation would be straightforward and it would be to just repair a perforated bowel?
That's correct.
But you've now understand that the surgery might have been a little more complex, is that right?
That's right, yes.
And that he needed to have a repair in terms of his stomach, is that right?
That's correct.
But the operation resulted in Grant then being admitted to the ICU, is that right?
Yes. Yes, that night.
And that once he was in intensive care, his position was quite grave, is that right?
Yes, that's correct.
Enough to call Naomi and to call Ren to come again?
Norm did, yes.
So Norm did that?
Yes.
Yep. And from what you both recall of watching Grant following the surgery, was that he was becoming distressed and that his behaviour indicated that he was experiencing pain, is that right?
Yes.
You had to make a difficult decision, is that right?
Yeah. Who's answered?
Who wants to talk about that?
Do you want to talk about that?
Difficult decision? You were with Dad when you made the difficult decision?
Well, after the operation, he went back to the normal ward. That night, at about midnight, I got woken up to a phone call to say, we have to go back to the hospital, Grant's going into ICU. Oh, okay, so up we went, and there's Grant on a breathing machine and all these other machines. He had to have blood. I was led to believe he was given 2 lots of blood in the ward and then 2 lots in ICU. And Karen arrived the next day, I believe, and I got some respite from being up there all the time because Karen took over night shifts and I went as a normal visitor, like a family member would rather than staying with him. And it was a couple of days later. All this happened with him.
He was back in surgical. So ICU staff were amazing. They talked to Grant like he was actually human. I guess they are used to having people that are not able to necessarily respond as in a normal way, but ICU was great. When we got back to surgical, that's when we had to model again for nurses to not just come in and lift the covers and start jabbing or doing treatments. You had to say, "Oh, Butch, the nurse is here. Is it okay for him to have do the blood pressure or whatever?" It was quite horrible to watch that. They just sort of thought that, and sometimes Grant was sleeping, and they'd just lift the covers and start working on him. And it was like, who does that, you know? For me, it was a stark contrast, because 14 months later, my father was in the same ward for an operation, and so Norm, the determined person, was in the ward for the same operation, being nursed by the same nurses, and they were completely different to him. They said, "Oh, Mr. Barnett, we're here to give you your medication or take your blood pressure. Is that okay?" You know? All right, and those type of things, and it was like a completely different thing. Anyway, getting back to the difficult decision.
Well, I think the difficult decision, I'm sorry to be oblique about it, but it was that by the 7th of April, Grant's condition is not good, but as a family, you decided that you were going to take him home?
Yes, well, we wanted to take him home at the beginning of Easter, which was, and we were told that there wasn't enough patient transport available to take him home, and we sort of said, well, we've got a bus, we can stick him in the wheelchair and take him home, but that wasn't okay. So Dad waited until after the Easter period, give them a bit of leeway, but again went up to the hospital and they basically said, no, it's against us. And this is in a public ward, no privacy. And we found in that conversation, I think, Tracy, you should talk about it because you were there.
Well, I didn't believe it was as grave as what it was until they kept telling us that Norm kept saying he wanted to take him home. Grant kept asking to go home. Want to go home, Dad, want to go home. And he goes, yes, mate, going to get you home. And as soon as he said that to Grant, the doctor's going, that's against doctor's orders to do that.
The medical advice was that it would be very unwise to have a discharge and to go home at that point in time.
Yes.
And but there had been discussions about what his arrangements might be if and when he left the hospital around aged care and the like. But Tracy, during this conversation, which was going back and forth between Norm and the doctor, Norm saying, I want to take him home, and the doctor saying, no, we counsel against that very strongly, you heard the words that made you think that his situation was one where he may not live to survive the hospital visit, and you raised whether or not he could be discharged and into palliative care.
That's correct, yes.
So you had picked up from the conversation that something was quite serious, and within half an hour of raising the option of palliative care, you say things swung into gear.
That's correct.
So what happened?
Once the doctor said to the words, there's nothing more we can do for Grant, I sort of thought, well, what is it when you can't do something for someone? I turned around and I said to the doctor, can we take him home on palliative care? And the doctor looked at her underling, as I call them, but another medical student, and said, yes, that can be done. And next thing you know, palliative care are there, organising it. What do you need? Within half an hour, I'm ringing Karen saying, more or less, get Grant's bed out. There's a bed arriving. There'll be suction and anything else we need. He's coming home on under palliative care.
Right. And
the bed arrived in less than half an hour, and the oxygen, etc., arrived in less than half an hour. It was unbelievable.
I think, Tracy, you say in your statement the palliative care team were extremely empathetic, helpful and efficient.
They were wonderful.
Amazing.
Wonderful,
both times.
So they arranged for Grant to have a morphine self-injector.
That's correct.
And they came to the home helped you.
Yeah, they explained all the medications that they drew up, all the medications, and if I needed them, what I had to do, and all that sort of stuff, how to sign off on it. And
very supportive.
Very supportive.
Amazing service. I can't fault palliative care or ICU. They're amazing.
So those final 2 days for Grant to be able to come home, and you knew you had that support of the palliative care, but he passed away, didn't he, a couple of days after coming home?
Karen and I beside him.
We didn't leave his side.
No.
And
slept by his bed, one on each side.
We in the ambulance on the way home, a plane came in and he was able to see the plane, which was great because Dad and Mum had actually bought the house near the airport so he could actually watch the planes as he got a little bit more immobile and stuff. And then that was really cool when I watched him, because he'd been cramping himself up in the ward. He'd been and he was cutting off his windpipe He was cutting off his windpipe. And I actually called a doctor at one stage and said, he said, well, there's not much we can do. And I said, yes, but, do something about this right now. And what he needed to do was come home, because we put him in his bed and he actually physically lied back and went, and then went, get mail. That was his duty from a very young age, and I had to go out to that mailbox and get the mail, because otherwise I was in deep strife, basically. So, yeah, he remembered his responsibilities all the while from that. But yeah, that was... He just wanted to be at home with us, and you could see him. While by the bed, he was just listening, like Dad and Remy, Dad's partner Remy, and other people around the place would be out having a cuppa or come in and visit and stuff like that. The telly was on, or, kids would be around, and he was just like, yeah, he was in and out of consciousness by that stage, but he was happy and he was interacting, and yeah, he was home with us where he needed to be.
Notwithstanding that it's close to 5 years, his death still causes both of you personally and your family a great deal of distress.
Oh, Dad's dead because of it. He left. Dad died 18 months after Grant, so he had palliative care again, and I directly believe that, well, he put off his own health conditions to
look after him.
Yeah, because he had to constantly fight and constantly be an advocate. He's, but one of my last conversations with my dad was, Dad, you could have gone off and had a holiday or something like that. And he said, I'd do it all again.
Right.
Do it all again.
So both of you decided after Grant's death that you were concerned and you wanted to follow a few things up. So Tracy, you wrote a letter to the coroner because you wanted to have an autopsy conducted.
Norm did, and
did that.
Norm asked for an autopsy because he wanted to know what went wrong. And he asked me to write my version of what I saw. And, yeah, I wrote it to the coroner because I thought, I'll do what Norm wants.
And in your statement, you say that you never received a response from the coroner after writing the letter, but you've been told, haven't you, that the coroner's office has done a search to see whether there was a response, and there may have been an administrative email sent to you in response to your letter, but you don't remember.
I don't recall getting a response, but it was very difficult times, and not long after Grant's funeral and that, I was given some respite, some time off, and then Norm sent me to Tasmania to look after his 92-year-old sister who had had a stroke in Tasmania.
Yeah.
But you're aware, aren't you, that an autopsy was conducted?
Yes.
Yes.
And you're aware, aren't you, that an autopsy report was prepared?
That's correct.
And are you, Tracy, is your best recollection that Norm received a copy
of the autopsy
report?
But I remember him showing to me, yes, but... Yeah.
And Ren, you've seen a copy of this as well?
The first time I saw the extended findings was the other day when the legal team rang up. I hadn't seen the 3 or 4 pages or whatever else. And I have to say I haven't read it yet because I was leaving it until after today because I found it too distressing.
Okay, so the autopsy report, and Commissioner says will be part of the exhibits, says the cause of death was first congestive cardiac failure.
Yep.
Secondly, hypertensive heart disease, and then also Klinefelter's syndrome and obesity. So has anybody told you that your brother's genetic condition was a cause of his death?
Nope.
You're now aware, aren't you, that in addition to the autopsy report, that the coroner also made some findings?
Yes.
And neither of you have seen a copy of the coroner's findings until you've been shown some of the documents for the hearing.
Last week, yes.
But you're now aware that the coroner issued some findings on the 10th of June 2015.
That's right.
And the coroner's findings in terms of the cause of death repeat what is in the autopsy report, and that includes a finding that Klinefelter's syndrome and obesity were one cause of death. You're aware of that?
Yes.
And in addition to making inquiries in relation to an autopsy and the work of the coroner, Norm also made a fairly extensive written complaint to the hospital. Is that right?
Actually, the family did.
The family.
He signed
So he
it,
signed it?
but I actually wrote that.
And so
Was that to the coroner or the hospital?
this is to whom it may concern, and so this was to the hospital.
Yeah, that was
understand.
co-composed by the family.
And it says the Barnett family and Tracy Nash and Norm has
Yep.
signed it. And you had lost a copy of this document.
That's
but
right.
You've been shown that in the course of preparing your evidence.
Oh no, I actually had a copy of that, or
Did have a copy?
a draft of it somewhere on my computer. I found a draft of that, but I couldn't find the emails that I'd attached that to.
All right. Do you remember either of you, Norm, receiving a letter from Queensland Health dated the 7th of September 2015 in response to Norm's letter? Were you aware of that?
I do. I remember getting a copy of that. Dad sent me a copy.
Right. So, and have you read this letter
Yes.
recently?
Oh, I skimmed over it today.
Right. And do you recall that in the letter, the author of the letter says that there'd been improvements to the service, including the adoption of what's called Ryan's Rule? Do you
Yeah, well, that
know
was in place. That was in place prior to. There was signs up all over the place, so it should have been in place already. So I think training about Ryan's Rule might have been a much better idea, and I guess training on how to relate to people with disabilities and to talk to people normally. And if you can't, if somebody doesn't respond in one way, then do it another way, because Butch wouldn't respond to people, like he needed Tracy to go, or Dad, he needed people he knew to get a response. We'd called it playing posse, and that's one of the reasons that in recovery that after that operation, that emergency procedure, that they left him all day in recovery.
Do you recall in this letter that the author says the following? I appreciate that communication processes can always be improved, and although our professional and many of our administrative and operational staff complete studies on this topic, I sincerely apologise that you felt at times staff did not portray these attributes to an acceptable standard. I admire your commitment to advocate on Grant's behalf in his dealings with our hospital and the health service. Do you remember that part of the letter?
Yes.
And you have become aware in very recent times that as at February this year, that the hospital has undertaken another review, but you haven't read that document.
No, I haven't read that document. It would have been nice to know so we could contribute, but
Did anybody from the hospital inform you at any time?
No.
From the 6th of February onwards that a review was undertaken?
No.
And other than the documents that you've been shown this morning, you were unaware of this review at all, is that right?
That's right. And I checked with my sister today as well, and she hadn't received anything anyway, and I don't understand that because because of communications, they had my email, they had my mobile number. There's no reason why. At least I shouldn't have been contacted.
All right. And have you read this document at all?
No.
Yet? All right. In the document, the hospital sets out some quality improvement initiatives since 2015. And one of them, and there's a number of them, so I'm not going to summarise these, Commissioners, but I just want to draw attention to one. One of the initiatives since 2015 is this. The adoption of, in inverted commas, hello, my name is ... is an initiative to ensure that staff introduce themselves and their roles to patients, families and their carers. You've said, Tracy, you're giving me a wry look there.
Oh, no.
But you've said, Tracy, that one of the things that you noticed is that people didn't introduce themselves when they came in. And so it appears that one of the adoptions of new initiatives since that time is a direction to ensure that staff say hello and say who they are.
Yes.
Is that a welcome improvement?
It is.
That
It
is
makes
a
me
great-
happy to know that.
Commissioners, you will have the benefit of the whole of this document, which is a fairly detailed account of various things, and this is part of the material that the Queensland Health Department wishes to tender in relation to the document.
Yes.
Right. Finally, and I'm just conscious of the time, Commissioners, both of you have said in your statement about the impact on you and some of the things that could be done better in terms of suggestions for change. Can I just briefly run through some of those with you both to make sure that we've captured them all? So, Tracy, you think doctors and nurses should be trained as to how to interact and engage and treat people with intellectual disability?
That's correct.
And you say this in paragraph 99. Health professionals should make themselves known to their patients and make known the role they are going to have with the patient's care. Even if this is as simple as, hello, I'm going to be your nurse for the day, or hello, do you remember me? And do you perhaps agree that maybe that suggestion has been taken up?
Yes.
You think medical staff should get to know their patients first before they commence their duties, and you look to there to be helpful engagement, so asking patients questions in a way that the patients can be able to answer. Is that right?
Yes, and get to know how does that patient react to a comment, or, you know, how do they answer, so I can then, or they can then adjust their answers or their questions accordingly to what they could respond to. Does that make sense? Yeah.
And you think there should be more transparency across the hospital system, that patients and families should have the right to know the outcome of complaints and incidents involving the people they care for. Is that right?
That's correct, yes.
And up until the information that you've been shown today or over the past couple of days, you were unaware that the hospital had undertaken the review, albeit almost 5 years after.
I only found out today, yes.
Right. Now, Karen, for you, your suggestions for change are at paragraph 68 through to 70. And you also identify training and the need to follow basic protocols. Is that right?
Yes.
And you say that you would also like to see doctors and nurses trained in recognising the meaning and significance of Ryan's rule, so that they can recognise that family members know the uniqueness of their own family member in terms of the care.
Yeah,
so
great.
You'd introduce Ryan's rule, but do you accept I've just read to you that
Yes.
the letter that went to Norm specifically noted Ryan's rule?
Yes.
And that you received an apology that maybe that the process hadn't been followed. And I'm paraphrasing there, but you've got the exact words that I've read out to you. And you also say you think there should be greater information sharing between the palliative care teams and the paramedics, and this related to just the circumstances of calling the ambulance after.
That was the most, I think for me, that was the most distressing thing. We had been looking after Butch overnight. We were very stressed. We'd had no sleep, and because Dad wanted an autopsy, we couldn't have the funeral directors that we wanted. We had to wait for the others, and we had to wait for the police. Luckily, Tracy had been informed by palliative care, if you do, the paramedics might arrive, like stormtroopers, give them the do not resuscitate. And the inference constantly was through from the paramedics while we waited for the police, and then the police, was that, why have you got a body here for 2 hours? Well, actually, I rang palliative care, and it was after hours because palliative care don't run it, and so I had to show them the phone. And the inference was that we'd murdered him and that we'd used the morphine to drug him so we didn't have to deal with him, and that was quite...
They noticed when they walked in was the morphine in the syringes on the table. Was like, who administers those? What's that doing there?
Why have you had a body
And
here
then
for
it's
2 hours?
Bag it all up, you know. It was like, What do they think we
And
did?
then ask for statements separately. And that's the last thing we needed as a grieving family, was that, like I just feel like the paramedics arrived, they come out of Bundaberg Hospital, palliative care is based in Bundaberg Hospital. There should be some, fair enough, the police mightn't have known, but the reality is that somebody should have known that everybody on a palliative care list need to be told, because you don't know if they're going to need an ambulance or something like that.
So that was something that you had in your recommendation?
Yes.
Finally, because you haven't read this and you may not know, the final sentence of the review report, which was finalised on the 14th of February this year, says this: the reviewing team convey their sympathies to the family and the carer for their loss. But no one's told you that, have they?
No.
He was healthy. He was the healthiest he ever was. He couldn't raid the fridge. He wasn't on diabetic medication. When he went in for that routine procedure, we were thinking months, years. He was dead 10 days later. That was premature for me. And that's like, oh my God, what happened? What happened to cause that? Yes, he might have had heart conditions and stuff like that. He was on medication for those things. He was on medication, well, he was off medication for diabetes because he was on the healthiest diet he'd never had, through a tube.
And he'd lost weight.
And he couldn't actually raid the fridge or the biscuit cupboard. So, and he couldn't have tobacco anymore. God.
Ladies, thank you very much for your evidence today. There may be some questions that the council representing Queensland Health may wish to make, and Commissioner, wanted to give you the opportunity if an application's to be made. Can we deal with that now and complete the evidence before we have a short break?
Yes. Are we going to have time to deal with the next witness?
When we finish this evidence, we might have a very short adjournment, and then I can give commissioners an update on where things are travelling. I've just been in the hearing room, obviously, so I'll just need to make some
thank you very
inquiries.
much.
But I just want to make sure that those representing Queensland Health, if they have an application to make, this would be the time to do it.
That's fine. Can I thank you both, Karen and Tracy, for your evidence? I know it's not easy to come and talk about the experiences that you have had and your experiences with Grant. So thank you very much for coming and sharing your story and Grant's story, and for the statement that you have made. What I suggest, if you don't mind, would you mind just perhaps, if rather than stay there, if you just go down and sit perhaps in the first row, and we'll just see what happens, if anything.
I don't have any application.
Thank you very much.
And that completes...
Providing the documents are tendered, no.
The documents will be tendered.
Yes.
But that completes the evidence. Thank you.
Thank you very much.
Thank you.
There will be no further questions. And Ms McMillan, we have the documents, I think, that are to be tendered, in fact. Insofar as one has been reading them.
I'm happy to read the documents to be tendered and on the transcript, so it's clear as to what documents are to be included.
Oh, I'm sorry, I'm not sure if Ms McMillan...
No, I hadn't finished. And we will want to put a supplementary statement in, because there's things that might have emerged in timelines that we will want to address about when we produce documents, etc. Thank you.
Thank you very much.
Well, perhaps if we have the break, Commissioners, and then I'll come back and I'll check that the exhibit numbers are
We'll take a break for a few minutes, and perhaps someone could let us know when you're
We
ready
will.
to...
Thank you.
Thank you.
The Royal Commission is adjourned.
something.
The Royal Commission has resumed.
Commissioners, I thank everybody who's in the hearing room, those who assist us in the logistics of the Royal Commission and those watching the webcast. It has been a long day and the Commission has covered a lot of evidence. So we've made a decision that we won't call the witness who was scheduled to give evidence now today, and she will give evidence on Friday morning. And we have sufficient time on Friday to complete the evidence. So all I need to do now is just formally deal with the tender of the material which I indicated earlier.
Yes.
And then if we can adjourn till 10 a.m. tomorrow. So can I formally tender and have marked as an exhibit Karen Barnett's statement, which will be exhibit 4.22.
Yes.
The statement of Tracy Nash will be exhibit 4.23. Now then we jump a little bit. So there is, which is tab 38A in the tender bundle, which is a letter from the Queensland Coroner to the Royal Commission dated the 14th of February 2020. That will become exhibit 4.35. The document which is behind tab 38 capital B, which is the autopsy report of Grant Jeffrey Barnett, that will become exhibit 4.36.
Yes.
The document at tab 38C, which is Form 20 capital A, Coroner's Finding and Notice of Completion of Coronial Investigation, will be exhibit 4.37.
That document is dated the 10th of June 2015.
Yes.
And just for completeness, the autopsy report is dated the 1st of June 2015. Yes.
The next is document behind tab 38 capital D. That is a letter from Queensland Health to Norm Barnett. That's dated 7 September 2015. And that will become exhibit 4.38.
4.38D?
No, 4.38.
4.38.
The next document, which is behind tab 38E, which is clinical case review of Grant Barnett, 6 February 2020, that will become exhibit 4.39.
Is that actually the 6th of February, or is the date the 14th of February, which appears on the last page of that document?
I thought the document was a sign-off on the 14th of February, but we've got in our notes 6 February. I think the document itself refers to a meeting date on the 6th of February 2020, but either date, I think the document's readily recognisable.
Yes, I think the 14th of February is the date of what is referred to as the case review sign-off by the Director of Medical Services. Yes, thank you.
The document at tab 38F, which is letter of complaint to Bundaberg Base Hospital, it's undated, but it is referred to in the material as a complaint made on 3 August.
Yes.
That will become exhibit 4.40. And then finally, I think I indicated that after we came back from the break, I would deal with the formal tender of Jane Leeming's statement, and that is tab 40 in the material, and that also includes the documents behind tabs, when I say the material, part A of the tender bundle. That also includes some documents at tab 41, 42 and 43, and together all of those documents will become exhibit 4.25. Sorry to labour that, but I just want to make sure that's clear for the transcript. So that otherwise concludes the proceedings for today.
Yes, thank you. Just let me check something, if I may. Ms McMillan, is there anything else that...
Ms McMillan's...
Oh, she's not there. All right. In that case, there won't be anything more from Ms McMillan. All right. Thank you very much. We'll adjourn until 10 o'clock tomorrow. Thank you.
Thank you.
The Royal Commission is adjourned.